And for those of you who are getting settled, you'll see that my colleague Winnie has asked in the chat box that you please go ahead and change your name in terms of how it appears on your screen in the first name, last name format. So those of us who are just meeting you for the first time know how to greet you. And for those of you who are presenters, please feel free after your last name to put the word presenter so folks are aware. All right. Well, it is officially 10:30 Eastern Standard Time and just about time to kick off our very first virtual conference. We are so excited to look at the participant numbers steadily going up. We have over 120 joining us so far, and we expect to have almost 250 people joining us globally for the next 3 days. Supremely exciting, especially considering the folks in the room right at 10:30 on the dot have already surpassed our usual number of attendees at our in-person conferences. So we're just tickled here at NaRCAD. So welcome everyone. Excited to see so many familiar faces and so many new faces. This will be very different, as I'm sure you know. The greatest thing we're excited about is that you can't complain about the snacks on our evaluation because there aren't any. They are all in your house. And also, we don't have to tell you any of the traditional housekeeping things like where the bathroom and coffee is because that's all you. And I hope that makes you feel good knowing that you can control the coffee quality. All right. So I'm going to kick off here. Those of you who've met me before know that I'm Devin Shigori, NaRCAD's Communications and Education Director. I am so excited to kick off our 8th annual International Conference on Academic Detailing. And for those of you who I haven't met yet, I look forward to meeting you in the future in person when the time is right. I'm going to introduce our team next and ask that they all just wave. So you've met me. I'm going to throw it over to our director, Dr. Mike Fisher. Mike, can you give a good wave?
Good morning. Welcome, everybody.
We also have Jerry Avorn, our co-director, who will unmute so you can say a quick hi as well. Jerry, we're so happy that you are tuning in with us today.
Welcome. Good to almost see you all.
Then we have Anna Morgan, our awesome program manager who has been with us for just over a year now, and we don't know how we would function without her. Anna, over to you.
Good morning, everyone. Welcome. We're so excited to have you here over the next 3 days.
And then over to Winnie Ho, who many of you have already interacted with via email. She's been the absolute pro manager of our registration and our program book. So I'll turn it over to her to say hello this morning.
Good morning, everyone. How are you doing?
And last but not least, we have our brand new events assistant who is part of our larger division of pharmacoepi, Sue Bean. And Sue Bean, I know you unmuted, but we didn't hear your voice. But anyway, I think everyone saw you waving. And for those of you who need to identify us here at NaRCAD, we are obviously in our fancy NaRCAD news anchor backgrounds with the turquoise and our logo. So happy to meet you all. All right. So a little bit of housekeeping to get you situated. I know many of you are Zoom pros. For those of you for whom it's new, and for those of you who need a refresher, we're going to tell you how the next couple days are going to work. So if you are able and camera ready, please turn your video on. If you have already said to us that you don't want to show up on our recording, again, we respect that and keep it off, but do know that during our breakout sessions, we're not recording. So hopefully you'll be able to engage on video. We will have everyone muted during presentations. As much as we love hearing the joyful sounds of children and dogs and cats and anything in between, we'll just go ahead and control that so you don't have to worry. And then if you use the raise hand function or pop a question into the chat box, we will respond as we can and unmute you to speak during the sessions where we have Q&A set aside. So again, use the chat box to ask questions. If it's something our internal team can respond to immediately, we will. If it's something based on the presentation that is happening at the moment, we will wait for the designated time to try and respond. And you can go ahead and set it so that your questions and comments are available and able to be read by everyone. We'll show you how to do that in just a second. Sadly, as much as we hate to say that we have limitations, we won't possibly get to all of your questions, but the exciting thing is in 2020, we launched our new discussion forum to continue this conversation, and we'll tell you how that works. For those of you who are already on there, you can mentor other folks. And for confidentiality in sharing, if you have any patient stories, please do anonymize and not use any specific information. And you'll see that Winnie went ahead and popped the discussion forum over in the chat box. We'll make sure you get all the links that appear over the course of the next 3 days at the end of the conference. We'll go ahead and send you out emails that have everything and anything that came up. So if you're trying to jot everything down, don't worry, we've got you covered. And if you have tech issues whatsoever, go ahead and send a private Zoom chat box message to the awesome ladies on our team, Winnie, Subine, and Anna. All right, so when there's a designated Q&A section, it will look like this on your screen. If we are able during certain presentations to integrate discussion questions throughout, we will let you know. As promised, we're going to show you how to adjust to speaker view. So you'll go ahead to the top of your Zoom screen and hit View Options. And you'll click Exit Full Screen. And then the top right, you can choose Speaker View so that when you see this sea of faces, you're not looking for the right person, it'll pop right up. Also, if you want to put your chat so that everyone sees what's going on, you'll go down to the bottom right and make sure that the drop-down menu is listed to everyone. All right, so before we get started, this is an ASZ. We want you all to make sure that you know that and respect that. Acronym-free zone. So for any of you who, naturally say things, the CDC and things like that, obviously, well, we all know what the CDC is. We hope the Centers for Disease Control. But if it's something familiar to you, don't forget that it might not be familiar to others. So first time you say it, please go ahead and explain what it is. This year, one different thing is you won't have a printed program book in front of you. However, it is just as awesome of a program book as every year. It features all of the bios of our amazing presenters, detailed session descriptions, and curated blog articles, including a feature from our very own Dr. Jerry Avorn, and much, much more. So please do check it out. It is a private link that will go public after the conference, but it is for folks who have registered officially, and you can find that at NaRCAD.org/2020 program. It's also in your registration information in your email. Today, we have a really exciting kickoff day. Obviously, we're in the welcome right now, and we're going to transition shortly to our day one address with Dr. Fisher. We'll go ahead and pop into some really cool field presentations. We'll give you a lunch break, of course, breakout sessions in the afternoon, an afternoon break, and then a plenary focus on AD in long-term care setting. If you want to learn more, please check out the program book. So on the menu, there's going to be a few traditional things and quite a bit of new things based on the platform we're doing here. So of course, we want to make sure interactivity is high. Although we can't create those coffee breaks where you can bump into an old pal or meet somebody new and shoot the breeze, and really connect, you can always directly chat with anybody who's participating. And right now we're up to 170 participants. So if it's someone new you want to meet and exchange emails with, if it's someone you haven't seen in a while that you're happy to connect with, do not hesitate to take any of our breaks to chat. We'd love that. We obviously want to focus on your thoughts and your solutions rather than speak at you and present at you. We want to know what you think. So please don't be shy to go ahead and send us questions, thoughts, comments, things that you'd like to share with other folks. this is actually a huge perk of being on this platform, because if you have a little thing to add, you certainly can't in person shout it out in the middle of a huge conference room unless you want to be really unique. But you can always say something on the chat box. If anybody wants to learn more about our program, which also features what was just being spoken of, please check out our link. And again, we'll gather all those resources. So I think that's a really cool thing about this platform, along with the fact that I am wearing sweatpants. Didactic presentations, meeting conversations. So again, we're going to do our best not to lecture at you. There will always be breaks to chat. Tradition is going to meet innovation in that way, and we'll show you in just a minute how we're going to have you hop on to poll everywhere. For those of you who have done it before, you know it's a lot of fun. For those of you who haven't, it's super easy and kind of a blast. We'll be learning together about how online convenings work. If there's something that seemed really terrific that you want to make sure we use in any of our future online offerings, let us know. If there's something that fell flat, let us know too. We're here to learn with you. Again, we want to connect you with peers to share those best practices, resources, and solutions. And we're going to talk about opportunities in 2021 so we can all feel a little bit more hopeful after a very challenging year. All right, as promised, we're going to have a little bit of fun here. So pick up your cell phones and send a text to the number 22333. And in that text, you'll put the word NaRCAD2020. And when you do that, you'll know you've done it successfully if this kind of little screen pops up. It'll say, you've joined NaRCAD's conference session. When you're done, reply, leave. But we hope you won't leave. All right, give us the thumbs up, either with your thumbs up icon, or you can just wave and thumbs up at us when you feel like you're all set with that. All right, thanks, Kelsey, for checking the box, the thumbs up box. Alita, Carolyn, awesome. So many familiar faces. Vishal, Lauren, Jackie. So great to see everybody, and really looking forward to meeting those of you who are new. All right, let's see if this worked. What do you think? Jerry, did you get it going? Awesome. All right, good, because the first question is about you. Let's just see if this works. All right, the originator of AD is A, Gary Acorn, B, Jerry Avorn, C, Mary K. Bjorn, D, Larry A. Thorne, or E, Harry Longhorn. So go ahead and if somebody wants to put the wrong answer just to see what happens, thank you, whoever did Harry Longhorn. Yep, beautiful. Oh, come on, let's have some feminism here. Somebody vote for Mary. There we go. And how about Gary Acorn? He's getting ready for the winter. He's getting ready to collect all the acorns. All right, beautiful. So now we know how this works. Let's talk about how are we feeling this morning, and especially after the weekend. And you'll see when we do these types of multiple choice, it'll kind of move in and out to show what percentages of people are responding. So good stuff. All right, next up, we're going to do a little bit of a mood word cloud. Pick a word and tell us, what's your current mood? Relaxed. Ooh, festive. Love it, love it, love it, love it. All right, look at all this. This is wonderful. Tired and hopeful. Yes, that's a nice combo. That is a nice combo. Optimistic, happy, Christmas, snackish, blah. I'm sorry for the blahs, whoever's feeling the blahs. And you'll see when a word gets bigger, like excited, tired, and hopeful seem to be, that means more than one person has said that. So now we have a sense of how that one works, and we'll do one more style of poll everywhere in just a moment. Content, grateful, contemplative, yes, intrigued, productive, awesome, wonderful. This is all good stuff. Frazzled, I'm right there with you, but also chill. Good stuff. Caffeinated is getting bigger as we go. Somebody wrote, I am feeling coffee. Wonderful. All right, so now we're going to switch over to one more. At this point, there are 185 people on the call. Where are you tuning in from? It looks like we had a run over from the last one. So let's have someone tune in from Happy. We love that. All right. Wow. We're just going to let this populate here. Look at it go. And I'll try to scroll down if I can. Ooh, to see. Keep tuning in. So people's, some of them are popping down to the bottom, but we're still getting a sense. I know we have people from Norway here, Australia. Amazing. Regina, Saskatchewan, Canada. I know who that. Actually, it could be multiple people. Beautiful. Somerville, that must be our very own Anna Morgan. All right, awesome. We'll give it one more second before we show you the map of where you are all coming in from, and we'll see if it matches up. Madbury, my parents live there. I got to figure out who that is. All right, wonderful. Got a lot of Chicago people. I know who that crew is. All right, so at this point, I want to share the map that our colleague Winnie put together so beautifully. So here is North America, and then here's a global view. Very cool. Really nice to see the reach. Obviously, there's such a concentration in North America that we'll have to kind of pop in there and make a little wiggle room to see who's who, but very lovely. All right, so now we all know how to do the interactivity. We'll also do a couple of Zoom polls, and in certain breakout groups, you'll end up just doing a chat waterfall. So lots of different ways to connect. Obviously, this past year has been rough. It has also created opportunities, and we are all doing the best that we can. So with that in mind, I'm sure you all know it's been a very steep learning curve within our own field of academic detailing. Again, we're expecting more than 200 folks, which is really so terrific because we know that having convenings in person really does make it challenging for folks who can't take the time, don't have the resources to hop on a plane. So we're really excited again to see all of you. And because of that steep learning curve, many of you have joined us for our ever-growing offerings in e-detailing, all of which have been informed by you, either telling us directly, sending us an email, joining and giving us your feedback in our post-session evaluations, as well as filling out our needs assessment on our website. If you haven't done that yet, please do and let us know what you need. Our blog is just off the hook this year. We have so many terrific articles written by Anna Morgan and Winnie Ho, our fabulous co-managers of the blog, and many of you have been featured. We hope for many more. We've kicked off this massive peer connection program with over 32 participants across the globe. So we've had folks from really everywhere participating with these one-to-one matches, participating in a closing virtual gathering that just wrapped up a couple weeks ago, and we're going to have a 2021 cohort. So do keep your eyes on your inbox. All of you who are already signed up for our mailing list and e-blasts, you'll just keep getting those. And those of you who are new, we've gone ahead and taken the liberty of signing you up. You are absolutely welcome to opt out if your inbox is overflowing. We've been fleshing out our AD literature archive, trying to grab everything of really high quality about AD. You can find that on our website, as well as archival and upcoming webinars on everything from looking at AD as part of a community-wide intervention to addressing clinician stigma and pivoting to e-detailing. I'm going to turn it over to Mike shortly, but not before announcing we have locked in our very first virtual training of 2021. We'd love you to join us. Registration opens on December 15th. Go ahead and jot that down in your calendar. It'll fill up quickly, but we are dedicated to having at least 4 sessions this year and making plenty of room for folks who have a large cohort within their own jurisdiction. So with that in mind, it's our top priority to learn from you as we head into 2021. For some reflections on 2020 and keeping the hope alive, I'm going to turn it over to Mike to kick off the day one address, a 2020 vision for commitment and renewal. Thanks, everyone, and over to Mike.
All right, super. Well, thank you, Bevan, for all of that. And let me add my voice to Bevan's, welcoming all of you. It is very exciting to see the numbers ticking up as we all have been watching you join us, and there is a real excitement about the ability to reach more people in this virtual format, as Bevan said, to have some of you who maybe weren't able to come to Boston for prior conferences and might not have been able to this year, to have an opportunity to join us virtually. And that really is a positive light in what has been a very challenging year. And that's part of that starts to touch on one of the themes I want to try to draw out, is to reflect on the strengths of our community, the fact that there are hundreds of us out there doing this work, and that even in a time when so much has felt so difficult, whether we can look for opportunities to expand our vision of academic detailing, to encompass the full range of opportunities that are out there to make practice better, to bring the evidence to clinicians, and in doing so, to improve the health of all of the populations that we serve. Before I go too much into the thematic material, I should just do the source of support for the conference and for myself. So the conference itself is supported primarily by a grant from the Agency for Healthcare Research and Quality here in the U.S. As always, we're extremely appreciative to them, but without core support from our division, started by Jerry when we started this conference series, it never would have gotten off the ground in the first place. Likewise, our resource center is primarily supported by a grant from AHRQ, but also gets support from several groups you see there, the CDC, NACHO, state programs. My current research projects, both through NaRCAD and other, are funded by the organizations you see there. SureScripts is a health technology company. My one personal disclosure is that I consult for Alosa Health, who you'll learn about. They are regular participants in the conference. They're a nonprofit that supports and conducts academic detailing. I don't do any other personal consulting. And DOPE, our division, will take unrestricted research grants from drug companies or health insurance or health technology companies for specific research questions, as long as we have the standard academic freedom to publish whatever we find. Okay, so let me return to the thematic material that I started introducing, because I do think that over the course of 2020, many of us have felt that we're in survival mode, that all we can do, and I think for many of us, this may have been personally, but also professionally, and certainly especially for frontline clinicians, that all that's possible is to sort of put one foot in front of the other, just get through the day without losing ground. And that's fair. I can't fault anyone, given the stresses of this year, for feeling that way. But I do want to use this opportunity, while we're all taking some time to join for a conference, to step away from the minute-to-minute pressures and be a little bit reflective, to suggest some opportunities that may be here, some ways that we can innovate, develop, thrive, deepen the meaning and the impact of the work we do. This is the beginning of our second decade. In October, we passed the 10-year mark since Jerry and I founded the Resource Center in the fall of 2010. And we do want to survive. We want to keep doing what we have been doing, and we've been doing some of that, putting one foot in front of the other to keep our core activities going. But we also want to use this doorway of our second decade to be thinking about how can we grow, how can we collaborate together, and how can we tap into that passion that motivated all of us to get into healthcare, to get into this field in the first place, and to be willing to do the hard work of going out, bringing the evidence to clinicians in a way that can really make a difference. So we've spoken quite a bit about adapting to the challenges for academic detailing, specifically in the pandemic. Bevan mentioned some of the community collaborations around e-detailing, and we really have been inspired and grateful for the way the community has come together, the response that there's been, and I have to say I'm incredibly impressed and appreciative of the work that our core team has done, but just as much so by the way that the community has responded. So we've talked about e-detailing in our forums. Jerry and I mentioned it in the welcome letter in the program book, Jerry's recent blog on academic detailing during a time of plague, which I'm sure many of you saw on the website, which we put in the program book. He'll be touching on some more on those themes tomorrow morning in his address, which as always remains the center point of the conference. And that's, of course, a really important topic for all of us, and actually important even regardless of the pandemic. But I do want to take a chance to reflect on a couple of other issues that to me have become especially salient this year, both in the setting of the pandemic and overall. So the first is to think about health disparities. the pandemic has made the importance of health disparities absolutely obvious. Just to pick out one recent data point that I'll show you, this is from JAMA, as the slide shows, and what it highlights on this graph, the bars going to the left and right, are the differences between the percentage of the population represented by a given racial or ethnic group in US states, and the percentage of the proportion of hospitalized patients represented by that group. There are 12 states in the paper. I just enlarged 4 here to keep it readable. And what you see in these states is the white population going to the left with a negative number, a much lower proportion of the population being hospitalized than is represented in the general population. And for Black and Hispanic groups, going in the other direction, far more patients from those groups ending up in the hospital. There are a range of similar data points that one could pull out. This is just a representative recent one. And so the pandemic has brought these into a place where none of us can ignore them. Of course, some of you may have been working on health disparities. There are many who've been researching and trying to intervene on these for decades, but I think with the pandemic, it's obvious to all of us at this point. I should take a moment to note that I'm addressing this with a US perspective because that's where I practice, where we are based. But I would suggest that disparities are an issue across country, or it's across communities. And of course, each location, either across nations or different regions within a nation, has distinctive challenges. But I do want to suggest that there are some universal concepts that we can draw out. Here in the US, health disparities, of course, have been a long-term problem that were highlighted by the pandemic. I think the issue has come into even sharper focus after the death of George Floyd in May and the resulting protests and larger awareness and conversation around some of the structural issues that underlie racial inequality. And it is important to recognize that many health disparities, many systematic issues are structural or systemic. And I don't want to be naive and suggest that with academic detailing, we're going to somehow fix those issues, as it were. But I do want to suggest that we can take this opportunity to reflect on how we work within the healthcare system and within the larger political, social, and economic system as academic detailers. And as we reflect, be introspective and ask ourselves, are we taking approaches that reflect the full range of settings in which care is delivered and outcomes are experienced, the full range of experiences that patients and clinicians have? And are our approaches providing benefits for those patients and those populations who may be at risk of worse outcomes due to health disparities? If we want to think about incorporating disparities into our work, we do need to take a different frame to think about seeing that bigger picture. So many of you have worked with us over the past 10 years on planning and implementing academic detailing interventions. And you know that one of the first things we do is assess the clinical problem and the patterns of care that we're looking at baseline. Well, when doing that, when assessing the clinical problem and planning an academic detailing intervention, as I've reflected on health disparities this year, I've been thinking about the importance of seeing the whole picture, considering all of the communities that might be impacted, and not necessarily assuming that if the average of a given outcome is okay, then no work is needed. The communities or the populations that face health disparities may be doing poorly relative to the community mean, which may look okay because those patients with built-in advantages, with good access to the healthcare system, good economic security, may be counterbalancing them. And so we need to think carefully about, are there opportunities to help, even if some arbitrary benchmark might look okay? When we're reviewing the evidence and crafting our messages, and of course, that's so much at the core of what we do. As part of pretty much every conference, we cite one of our Australian colleagues years ago who described academic detailers as ambassadors of the evidence. And we are, but sometimes being an ambassador means reflecting both the positives and recognizing the blind spots and limitations. And we do need to be aware of how disparities shape the research literature. the fact that your classic research studies might not include patients, say, with who face disparities based on their physical ability, certainly their race and ethnicity, the old or the very old. So we need to keep these things in mind when we begin to implement our academic detailing interventions. In addition to using this framework to shape how we evaluate the evidence and craft our messages, we should be field testing those messages with community stakeholders, with others, to understand how health disparities manifest in a given setting. Again, those of you who've worked with us over the years know that we always talk about that engagement with local champions, with stakeholders. But as I've reflected on the challenges of health disparities, I've thought about the fact that I come at it from the lens of a physician, of a primary care physician. And so I'm thinking about key stakeholders as the chief medical officer of a local hospital, the head of a local public health agency, not necessarily community groups or others who might be able to give the insights about how health disparities might limit the reach of our intervention, how a really well-designed intervention in terms of how it uses the evidence might inadvertently reflect or perpetuate pre-existing disparities if only a certain subset of patients who have good access to care, have good health literacy, are able to take advantage of the resources that we create. So as we look at this, as we broaden our view, we all need to be willing to adjust, to innovate, to recognize our blind spots, and be willing to take some chances based on what we're learning. As we start to think carefully about how a focus on healthcare disparities might inform and affect our work, a place where I've been thinking about that is in terms of how we might incorporate the social determinants of health into academic detailing in a more deliberate and more comprehensive way. Again, increasingly across the medical and research communities, we're recognizing the importance of these what are sometimes thought of as non-medical factors that may determine patient outcomes, whether economic, whether educational, whether housing related, and there's a wide range of these social determinants of health. They may have more of an impact on patient outcomes than the testing or treatment approaches that we take as clinicians and that we as academic detailers work on our clinicians to improve. So the challenge for us is whether we can envision academic detailing approaches that can help clinicians learn about the social determinants of health, but in particular identify practical ways to incorporate that knowledge into their clinical practice. So as we recognize the important role that detailing can play, and we think about educating clinicians about social determinants of health, which can be a challenging issue, I'd suggest that's exactly the kind of issue that can fit into the framework of academic detailing interventions, where one of the original insights, going back to Jerry's first studies, begun more than 40 years ago now, was the power in that one-on-one conversation where you can really find out, what does a clinician know? What do they not know? Get someone to be open about the limitations, the places they'd like to learn more. I think for many of us, we don't learn about these factors in our medical or nursing or pharmacy training. And there's an opportunity with academic detailing to engage. We've begun to explore some of this really through things that were brought to us by you in the broader community. So I would definitely encourage people to look back at a couple of prior conference sessions on the Conference Hub. There have been great sessions on the role of stigma and how academic detailing can engage with clinicians to explore the barriers created by stigma for issues like addressing opioid use disorder or HIV prevention. We've actually recently begun a really exciting pilot project working together with NACCHO to incorporate material on adverse childhood events and trauma-informed care into academic detailing interventions so that clinicians will be better prepared. But there's so much more work to do in that area. And I'd suggest that we really need to be open to including other voices and perspectives. One of the exciting things about this conference series is we do get a chance to learn from so many others from the broader community. And so as we think about under recognizing healthcare disparities, perhaps looking for interventions that can incorporate the social determinants of health, we need to ensure that we're considering a range of voices and perspectives, and to come to this with a spirit of humility and inquiry, not necessarily assume that we have all the answers. Many of us are experts on our given clinical domain, experts on reviewing the evidence and framing traditional epidemiologic questions. And that reflects the traditionally very hierarchical nature of healthcare. But this perhaps can be an opportunity to consider the perspectives of the patients and communities who experience disparities. And to the extent that we can recognize those experiences, include those perspectives and voices in the shaping of our interventions, I'd like to suggest to you that it can be a pathway that will lead us towards more robust interventions and eventually towards better outcomes for the larger communities and populations that we eventually serve. So if that's one aspect of the challenge, I do want to say, though, that I don't think simply increasing our awareness is enough, because while I've been saying for the first few minutes here, the idea that there is a lot that we don't know and perspectives we don't consider, and that it is important for us to learn about it and recognize it. Just saying that we understand that those exist and having our awareness raised isn't enough. There is that companion piece to it, that we bring a great deal to the table, that we as academic detailers can implement with high quality, rigorous reviews of the evidence, have that real focus on practical action-oriented messages that lead to action. And so we can take the framework that we bring as academic detailers and not sacrifice any of that rigor as we try to look carefully at the literature on healthcare disparities, perhaps from other traditions than the standard healthcare literature, but we can do that with quality. So that brings me to the second major challenge that to me has become much clearer in the pandemic that I want to focus on before I'll tie these threads together as we conclude. And those are some of the challenges that have come up as we think about our core element of interpreting research in the research literature. So the focus of academic detailing, again, as is so often the case when a new challenge comes up, we can look back to the original studies that Jerry and others did to recognize where these issues came from. So the original studies recognized that frontline clinicians didn't have the time or always necessarily the expertise to go through a complex research literature and distill out the usable components. But that core element of academic detailing that's been there from the beginning was based on a model of the literature that's relatively conservative and static in the way that it comes to us. Even then it was clear that not all literature is created equal, that some studies are of higher quality than others, that there's sort of a gray literature of not as rigorously peer-reviewed articles and so on. But it was a more static body of knowledge. But the experience of having a large volume that is growing has been dramatically amplified by the pandemic. We've had across the world and in every community, clinicians who are trying to diagnose and advise and treat patients with very limited information. That's not even mentioning the very limited physical resources. But and having been in that situation myself, and I'm sure all of you participating today who work in clinical settings can identify that with this feeling of the sense of people coming to us for advice about should they be using medications or not, and if so, how? What actions are safe to take in the community or in their homes? How do they manage a real or a potential exposure? All of these are things that we as clinicians want to advise our patients about, and yet we don't know how. And that can be a really powerless feeling as a clinician. So as clinicians, we're hungry for that reliable data. We want something we can do for our patients. Unfortunately, in the initial phases of the pandemic, a lot of what we had to give our clinicians was junk food. So there was a large volume of data being released. I'm only going to put this up for a second, but this was one of the very early studies of showing that hydroxychloroquine supposedly led to rapid cure of COVID disease. This was picked up very widely. But then if we look at a study from a more recent, better done paper that came out in JAMA just this week. This actually looks at hydroxychloroquine, and the two curves here are survival and time to hospital discharge, and they essentially overlap, showing, along with a larger body of data, that hydroxychloroquine in fact doesn't work. But we do have to think about, as we return to the idea of the clinicians who are so hungry for data, about what was lost through the flurry of attention on hydroxychloroquine as a treatment, not just in the wasted resources and effort in hoarding the medication, giving it to patients who it maybe didn't help, but also the amount of research that was done based on faulty premises. And all of this would be true even if there wasn't the problematic political communication about hydroxychloroquine. So as clinicians are hungry for that data, researchers and journals have been trying to fill that void, generating new studies, new papers at a remarkable rate. And there's new models of pre-publication. A lot of the COVID-related studies have come out on something called NaRCAD2020. It's NaRCAD2020, that I'm sure many of you have seen. And that bypasses traditional gatekeepers. And there can be positives to that. Shaking up our traditional systems of knowledge can have a positive impact. For example, back, and this was actually an earlier thing that involved Dr. Tony Fauci, back in the early days of the HIV epidemic, due to patient advocacy, some of the models of when drugs were released as they were going through the research process were shaken up, and that ended up being helpful for a lot of patients. So I'm not saying that bypassing the traditional gatekeepers is always negative, but in this setting, it makes the problem for frontline clinicians even harder as they struggle to keep up with all of the information that's coming out. I'd suggest, however, that these new models are likely here to stay. As people get used to releasing information more rapidly, to having it available sooner, clinicians and research and the community will expect it, and researchers will want to keep doing it. So we all now are challenged as a community to think about how we can do valid evidence reviews, how we can stick to those fundamental principles of high quality academic detailing when there's more evidence available and when those traditional gatekeepers may not narrow the flow for us. And the argument that I made earlier about disparities and social determinants of health as important elements that we need to incorporate suggests that in addition to the flow being faster, we also need to broaden the range of literature that we're looking at when developing our programs. Well, that can really seem like an overwhelming mandate. But what I want to suggest is if we're going to try to meet this challenge when everyone is already so busy, we need to think about ways to work more efficiently, more collaboratively, not to necessarily say to everybody, just work harder, but to find ways to include the views and the expertise of all groups, of all of those who have a stake in academic detailing and in the overall improvement of the quality of care. So to me, I think this opportunity for more collaborative processes is a chance that we can leverage, is a place where we can look at the turnout, the fact that we have over 200 people who've registered and will be joining us at some point over these 3 days, almost 200 of you who are on right at this moment, that we really are more connected than we have been, even though the pandemic has had distinctive features in a given country or a given region. It truly is an international phenomenon. All of us are struggling together to figure out this evidence. Across the academic detailing community, we've seen colleagues doing amazing work to review research, identify the best evidence to inform academic detailing interventions. Many now for the pandemic, but also trying to keep up their work on all of the other underlying healthcare challenges that are still there, even in this time. But we also see tremendous duplication of effort. So many talented people doing very parallel work for the same problems in different locations because they're not in touch with each other. So as we think about how we can incorporate those new elements I've outlined into our processes, I want to be thinking about ways that we can pool our efforts, share resources, think about distributed models for evidence review so that we can remain curious and open to innovation. Part of our role is to keep that hope alive, to provide space for these ideas, these processes to develop. Now, our conference theme remains sustainability, and it's actually one we had chosen even before the pandemic hit. And we do recognize the importance of that. All of you in our community are the ones out there on the front lines doing this work. And we, just as we've been working through the year to sustain our activities as a resource center, we want to be here to help all of you sustain your work, figure out how to maintain your funding, keep your personnel engaged, stay connected to your stakeholders. But we also want to create that space for our community to work together and to think about ways that we can share new ideas. The communities that our team, that Bevan and Anna and Winnie have been creating, that have connected you across not just parts of the US, but across countries and continents, offer the potential to both sustain our work from that nuts and bolts perspective, but also to sustain the interest and passion that drove us to get into this field in the first place, that drive clinicians and that allow for innovation. I think what we've seen as we focus on success, and that's where I want to close as we move to the conference, is to be inspired by the resilience of our community. What we've proven over the past 8 or 9 months, the lens of academic detailing implementation has been expanding to include more and more clinical diversity, considering of health disparities, things like stigma and trauma-informed care. But we don't want to be so future focused that we lose sight of all of your successes. We're incredibly proud of what you've already accomplished and what you'll be sharing over the next 3 days. And my invitation and my challenge to all of you is to stay connected, to deepen your connection with us, to share your ideas. I'm hoping that I've given you some inspiration, if I've been fortunate enough to connect, to have those ideas, to reach out. And we want to innovate with you to build the successes we'll be hearing about at the 2021, 22, and onward conferences as we continue to grow together. We're really looking forward to what you'll share over the next 3 days, and we're going to be kicking it off appropriately with field presentations on clinical diversity, reflecting the populations we serve: veterans, patients with a burden of mental illness, underserved women of color. And it's a perfect way to transition into the work that all of you do. So thank you for being here. Thank you for listening to the first session. And now Bevan's going to tell us a little bit about what this first set of presentations will cover.
All right. Can we clap on a virtual conference? I would like to clap. I would like to give you a little clapperoonie. That was wonderful. Thank you, Mike. And I think really what a wonderful transition to this awesome upcoming field presentation panel. And thank you to all of the presenters for being so flexible when putting in your submissions before COVID hit and being willing to switch hit along with us. So thank you for that. And again, thank you, Mike, for kicking off these 3 days with some hope during a time when we really, really need it. So how this is going to work is, it's just about 11:15. I'm going to turn it over to Mike, who will moderate this and provide a bit of an introduction. And then each of the following 3 presenters will have 15 minutes to present with 5 minutes for your Q&A. At the end of the 3 sessions, we'll then open it up to a broader Q&A where you can ask any of them anything. So without further ado, I'll turn it over to Mike. And just at about 11:20, we'll have 20 minutes for Sarah T. Green. We'll have 20 minutes for Mark Fontavong and 20 for Nate Rickles. And I don't think I can pick which of these is my favorite. So back over to Mike to introduce Sarah and kick us off.
Excellent. So excited to have this session and to introduce Sarah T. Green, who is the project coordinator for the psychotherapy academic detailing pilot, and is in the National Evidence-Based Psychotherapy Program in the VA's Office of Mental Health and Suicide Prevention. For our international attendees, the Veterans Health Administration provides care here in the U.S. to our large population of veterans, and Sarah will be telling us more about that. Sarah is a clinical psychologist, in addition to her work on academic detailing, based in the Durham VA system. She's the assistant division chief for outpatient mental health, and coordinates team-based care evidence focused on best practices on managing outpatient mental health programming. And she has been working on implementation initiatives for the National Evidence-Based Practice Program for over 2 years now, specifically coordinating this project on adaptive academic detailing. So let me turn it over to Sarah for her presentation. As Bevan mentioned, please do feel free to put questions in the chat as you're going, because we'll have some question and answer time at the end. Sarah, over to you. Thanks for being with us.
Oh, and it looks like you are unmuted, but we can't quite hear you yet.
Okay.
There you are. All right.
Can you hear me now?
Yeah, thanks for kicking off our very first tech glitch. There will be more. All right, over to Sarah.
All right. Okay, just let me know if there's anything interrupting me. But thank you, everybody. It's wonderful to be here. I'm very excited to present on this innovative pilot that we have. Difficult to hear, sorry. Okay.
No, you're good.
Okay. I'm going to be presenting on this innovative pilot that we started as a major push in the National Evidence-Based Psychotherapy Program for the Veterans Health Administration. And we very much partnered with the Academic Detailing Service in the Pharmacy Benefits Management Program with the VA. So these are my collaborators, and I have no financial or other relationships to disclose as part of this project. And to get us started, as the presentation title hints at, this is a bit of an adaptation. So I'm curious to hear from all of you if in your programs, if you are detailing folks who are not medical, so not medically affiliated in terms of physicians or nurses or PharmDs. Okay. So it looks like overwhelmingly that is rare. So this will hopefully be interesting for those of you who have not heard of this concept to think through what it might be like to detail people who are not particularly prescribers or in a medical sort of discipline. Great.
All right, and we'll ask folks to take a break from responding to that poll because there'll be another one coming up. We want to make sure we keep the data clean. All right.
Okay, so kind of piggybacking on that one, now I'm wondering how many of you in your detailing programs have detailers who are not medically affiliated. So folks who are actually serving in an academic detailer role and are not a prescriber or in a medical oriented discipline. So again, these are probably lining up. And I am new to the academic detailing world myself as coordinator for this project, but I had long suspected from my interactions that this is a very rare sort of setup and that most folks are in a medical discipline and also promoting best practices to other medically oriented providers. So I'm going to be talking about what we did in this particular project that is different, and it was an adaptation for us. All right, so kind of going backwards a little bit to some context for what started this pilot. Depression as a mental health condition is very prevalent, not only just in the general population, but specifically for U.S. veterans. It is highly prevalent in our VA healthcare seeking population. And suicide has become a national focus in the U.S. for U.S. veterans, where they are more likely to die from suicide than our civilian counterparts. So suicide prevention is a major component of VA mental health care, and depression is linked to suicide in that if you're not treating an underlying mental health condition, you're much more at risk of becoming a suicide victim. So the National Mental Health Guidelines suggest that every patient should be very thoroughly treated for any underlying mental or medical conditions that might put them at risk for suicide. So that kind of sets us up a little bit to be thinking about how are we, and you can go on to the next slide, that's fine. How are we really teaching our clinicians how to prevent suicide by way of treating depression? And in the National Evidence-Based Psychotherapy Program in the VA, we are in the training business. So we have very thorough training programs to teach clinicians how to treat depression. And there are 3 nationally recognized treatment programs that are what we're going to call EBPs, evidence-based psychotherapies, that the national program has rolled out training in all 3 of these for years. And that means pretty prolonged workshops and consultation for 6 months on various cases. So psychotherapists in the VA, who might be clinical social workers, might be clinical psychologists, marriage and family therapists, they all have the opportunity to get trained in these treatments. And over the years, we've trained over 2,500 clinicians across the US in these 3 particular treatments. And our outcome data, just from our own program, shows us clearly that these 3 treatments lead to decreases in suicidal ideation. So even early on in treatment, it is in a veteran's best interest to be getting one of those treatments, and they are much less likely to be thinking about and contemplating suicide. Now, training is not enough, and that's what kind of kicked off this pilot. So in years past, we have provided trainings, clinicians apply to come to the trainings, and yet our evidence of how these treatments are used post-training is not suggesting that it's highly utilized. So currently, we have electronic medical records, and there are specific documentation templates that we ask everybody to use when they are using one of these 3 EBP treatments. And that utilization of those documents is so low. So like 0.5% of most clinicians are entering in their medical record that they're actually utilizing one of these protocols with depressed veterans. So despite the robust training, we're really missing an implementation focus, and we're not really clear on how widespread the adoption is. And there's a little bit of a joke that if you have been to one VA, you've been to one VA because they are all, for better or worse, very autonomously run, and guidelines can be interpreted differently at a local level. Systems can look different at local levels. And so that's one of our huge system barriers, is just how different all of the scheduling practices, how care is flowing through each facility. The culture of each facility can vary. And then clinician barriers, really thinking about what's getting in the way of a psychotherapist wanting to just pick up and use one of these treatments. Is there a misperception of how useful they are? Are there different training backgrounds that folks are coming from that make it less uniform? But what we know is that if people do prioritize it, this is the system that we would like to see. So this model kind of shows that when providers are able to successfully adopt and implement these treatments, they're much more likely to be operating on a recovery model. These are time-limited protocols where veterans come weekly for generally anywhere from 12 to 16 sessions. So within 3 to 5 months, veterans can actually see significant reductions in their symptoms, their goals for their mental health care can be realized, and they might actually terminate their mental health care and exit the system, which would allow for greater access because we have more and more veterans in droves coming into our VA healthcare system. So to create, a recovery-oriented system is our goal, but we must have people cooperating with the treatments that will actually get people better in order to reach that goal. Otherwise, a bottleneck occurs. So we started to turn to our partners in the Pharmacy Benefits Management Program at the VA and the Academic Detailing Service, and noticed that they have a lot going for them beyond just sending email blasts and having some didactics to say, hey, these are great treatments. We noticed that they are quite successful at getting provider practices to change in the medical field through the combination of tools that is academic detailing. So we really got curious about that, and it's not something we had really known much about in the mental health field prior to getting into this project. And so to take a look at where academic detailing fits in, what you're going to see around the perimeter, the outside circle, are all the key players at a local facility for good mental health care. We actually have the evidence-based psychotherapy providers. We need those people who've been trained to actually use the treatment. There's also local evidence-based psychotherapy coordinators at each facility who are meant to help coordinate training opportunities, give these kind of didactic sort of reminders and email information about best practices. And of course, you can imagine there's referring providers, so physicians in primary care, psychiatrists who might not be doing the therapy themselves, but we would like them to be informed and be able to provide referrals for these treatments. And then all of the managing pieces, so leadership and mental health. We really looked at this as our psychotherapy academic detailer could be the center that kind of glues all of these pieces together, helping leaders to understand the importance of these best practices, talking with providers one-on-one about how to improve the practice and the flow, and hoping that all of it would start to shift in a better direction. So we trained just 20. So again, this was a pilot project. So we trained 20 psychotherapists who were coming from either a psychology or a social work background. We trained 20 of them at a 3-day training workshop sponsored by our pharmacy counterparts. This was funded from the Office of Mental Health and Suicide Prevention, but we basically were adopted by our academic detailing service, and they took us under their wing and very much gave us all the training material we would need, gave us a lot of support to be able to keep consulting, and they let us use their Salesforce platform for documenting outreach visits, support activities, so that we could get printouts. Mark Bountafong, who's on the next talk, actually is integral to this project and helped us run the data analyses. So we became really good friends and great partners through this. Each of our detailers had 10 hours a week that we were supporting their salary from their local VA. The National EBP program bought out their salaries for that particular portion. And they logged their efforts. They met with me. I was employed as a half-time coordinator for this project. And then we would provide kind of ongoing reminders of motivational communication strategies and some problem solving around any kind of system barriers that they might have run into.
It looks like Sarah might be frozen at the moment. So we'll go ahead.
I can hear you. I just,
so Sarah,
yeah, my computer is.
That's quite all right. Can you see us okay? Can you see the content?
I think it's reconnecting, but I can pull it up on my end and keep rolling. So
okay, no worries.
Really quick.
So while you're pulling that up, again, this has been so interesting so far, and again, just such a great kickoff to finding an innovative way to look outside the traditional, clinician to clinician, doctor to doctor approach. And it really looks so far just so exciting. And I know Mike himself has questions, and folks who have questions as we go, do not hesitate to pop them in the chat box so we can get ready to go as soon as Sarah is wrapped up. So Sarah, how are you doing? Are you ready with your slides?
I can see my slides. It's still on my end for my Zoom is saying connecting. So
no worries.
I'm glad I have
we can
the
hear
phone audio. So I will just keep talking through my slides, and I will let you know which slide I'm on.
Okay, sounds good.
Okay, so I'm on the one with the blue background about the key messages.
You got it. You got it.
Okay, cool. And so these are the messages that we really trained our detailers to be promoting for this particular, we called it an EBP campaign, so evidence-based psychotherapy campaign. And basically, we wanted them to talk to people about providing the EBP if they have been trained in it themselves and have been one of the successful workshop participants. We wanted them to refer to people who could do the treatment if they weren't themselves known to be able to do it, if they happen to be a prescriber, for instance, or just didn't have the background. And then we wanted them to use the note templates if they were trained in it, so that we could really thoroughly document and see more of a direct correlation between the use of the EBP and what's documented in the record. We also tied in measurement-based care, which is an initiative to have assessment be an evidence-based practice for making treatment decisions. So when somebody gives a PHQ-9, which is a patient health questionnaire that is 9 questions about mood and depression symptoms, that helps inform them about whether or not this is a clinically significant case of depression where they might want to do a course of treatment. It also helps to inform when they might stop treatment, if they're meeting their goals or not. So we were really promoting using the PHQ-9 as part of this campaign. And then we also wanted to reinforce the fact that if you're using these treatments, it creates a recovery model, which creates a little bit more of a revolving door of opportunity for treatment instead of a bottleneck. So those were our key messages. And then moving on to the detailer activity data. So we had 20 detailers. They were positioned across 19 different sites in 8 different regions. And you can see here, you know, they were quite active. Quite a bit of outreach visits. This spanned the course of about 15 months that we were looking at. And again, they only had 10 hours a week to do this. And then they quite frequently had return visits. So we were, you know, asking them to start relationships with folks over time. Okay, and so then moving on to the actual data slides, what you'll see here, we did an interrupted time series analysis. So we are taking the pre-intervention phase as being 12 months prior to any contact with one of our psychotherapy academic detailers and looking at what is the amount of EBP documentation that was going on for the folks that our detailers visited prior to them visiting with them. Then you see everybody's start date kind of gets crunched in our analyses. So it was actually different dates when people started meeting with detailers, but this particular set of data allows us to crunch all those start dates together and look at it as one particular timeline. And so once someone started meeting with a detailer, their use of EBP templates, which indicates that they are using the EBP, jumped way up. And so that is an indicator that having the detailer was impactful on actual use of EBPs and documenting such. Then we see a little bit of a trend that it starts to backslide a little bit. That was not a significant backslide, but it is something that we, you know, want to kind of contemplate and pay attention to. It might indicate that we need ongoing interaction with the detailer in order to keep making the most of it rather than a drop off after they've visited once or twice. The next slide you'll see is just our PHQ-9 administrations, and what that looks like is quite similar, except we have an ongoing upward trend. So for whatever reason that we could speculate, folks were decreasing in the amount of measurement-based care with the PHQ-9 and how much they were actually looking at depression symptoms through that mechanism. Then when we met with the detailer, it significantly jumped up. So that was an impactful intervention. And then it kept climbing. So post-detailer, you know, we have speculated maybe that is a simpler thing to change in terms of behavior. You give it and it's like a 5-minute measure versus a whole course of psychotherapy that might be very different for behavior change. But for whatever reason, those findings were much more robust. So kind of rounding out our conclusions, you know, psychotherapy academic detailing appeared successful. It certainly made a significant impact in the way that people were documenting their care and the use of measurement. It did look like it might be more robust on the more simple behavior change. And so it could be that some of our system issues are still at play, and there is lots of variability in clinician training and their competence levels, and also the referral structures and all of the scheduling practices at each site to allow for people to use EBPs. And so our key takeaways, that psychotherapy is less regulated at the VA than some of our prescribing disciplines, and their practices might be a little bit more straightforward. Psychotherapy tends to be heterogeneous as a field in terms of the theories behind it and what people view as the mechanisms of change. So we might have a little bit more of an uphill battle to convince everybody that the evidence we're looking at is the way to go. And it also looks like it's going to take a lot of effort locally over time to really sustain changes and get a more robust adoption going of these EBPs. It also has great implications for the adaptiveness of AD. So as I noticed at the beginning, when a lot of you said that you have not had these sorts of adaptations, it's really promising that you really could train non-medical folks to be detailers, and that you might also find success detailing non-medical folks on other issues other than potentially prescribing practices, which might be more traditional. So that is all really exciting stuff. And of course, through this, we learned a lot about our training program and what we might want to do to try to get more precise in our marketing, how we are showing people what EBPs are, the process for people to apply for trainings, and then how we're capturing their workload afterwards in the best way possible. So with that, I'm going to conclude, and it looks like I had a slight internet problem, so I'm going to try to click back on the link. I am not yet back in the Zoom meeting, but if anyone wants to read out loud any quick questions in the chat box.
I'm happy to do that, Sarah. And thanks so much for being flexible and staying cool, calm, and collected when the inevitable tech glitches come up. All right, so we have quite a few questions, and we'll make sure we fit everybody else's presentations in time before lunch. So we'll take a couple minutes. We have 3 great questions here. The first is, so Narissa from Chicago says, it sounds like a great campaign. Sorry if I missed it, but can you clarify who the psychotherapy detailers are, i.e. LCSWs, LCPCs, et cetera? So can you just give us a sense of their backgrounds?
Yes. I believe that like 16 of the 20 were clinical psychologists. All within the VA, all clinicians who had been trained in one of these EBPs prior to this project. So they were kind of our champions who did not need a lot of convincing. A few of them were clinical social workers. So just a difference in some training backgrounds and approach, but they had all been trained in one of these EBPs prior to starting this project.
Awesome. Thanks for the great question, Narissa, and for kicking us off. So we also have a question from Elisa Shields in Oregon. Hey, Lisa. So she says, this is fantastic. Was there any messaging on lethal means reduction or only depression treatment?
That's a great question. For this particular one, it was just on the actual treatment. So there are other programs in the VA focused much more on the tangible, here and now, how do we reduce your risk? This was more long-term, looking at how do we do prevention from more of a public health perspective, just with the treatment aspect.
Awesome. All right. Alicia Christensen from the CDC also says this is fabulous. Are these results published yet? Because she's really interested in results around adaptations.
The results are not yet published, but we do plan to write them up and submit them during this fiscal year. And if anybody has particular questions about adaptiveness or any thoughts, that I would be happy to chat, or you can reach me by email to talk about more of what we did and what you might be thinking.
All right, we have 2 more, and then we'll move on to Mark's presentation. So we have one from Cindy who says, were you able to capture data on when therapy starts because it's all in the same EHR?
Okay, I may not fully understand that question. So the therapy part, the people that were being detailed were therapists themselves in ongoing cases. So we were kind of asking them, hey, if you have cases already going in these EBPs, please document that. And if you're not using the EBP, why not? And that became the focus of the academic detailing outreach visits. So they might have started and stopped different cases while being detailed.
Awesome, thanks. And Cindy, if there's anything you want to add to that before our last question, please go ahead. If Sarah, if you wanted her to elaborate on anything further. And the last one we have before we move on to Mark, from Kelly Kretzer, what was the perception from the providers of being detailed in a non-peer-to-peer setting? Can you give us a little nugget about that, Sarah?
Yeah, so it actually became a peer-to-peer setting. So our academic detailers were psychotherapists detailing other psychotherapists for a large portion of it. There were some instances where they were detailing psychiatrists, or leadership in mental health. But otherwise, it was a therapist detailing another therapist about the benefits of EVPs, which was a little bit strange for the perception of the detailers who are not used to the academic detailing world to kind of get over a hump of marketing and being willing to use their communication techniques that they were used to with therapy clients on their peers. So it was more their perception getting over it, and it was a little bit new for some of the therapists to have a detailer. So it just wasn't part of their world. So we had to explain a lot about what academic detailing was and what we were doing.
Awesome. Sarah, thanks so much. This is a great kickoff as our first presentation at NaRCAD 2020. And without further ado, we'll transition to our other friend and colleague at the Veterans Health Administration. Not that there's just two, we love your whole team. So over to Mark Bontavong. Mark, it's great to have you back. You've always been such a lovely presenter. So we'll have you kick off. And Mike, would you like to introduce Mark?
Yeah, absolutely. So thank you, Sarah, and thank you everyone for the questions. But to give Mark a proper introduction, even though he's become an old friend of NaRCAD, he's the National Clinical Program Manager for the VA's PBM academic detailing service that you just heard about from Sarah. He's been at the VA going back to 2007, working as a pharmacoeconomist. That's a word I should be able to pronounce given the division in which we're housed. But he's been working for the last 4 years as one of the national data managers in the academic detailing services. He's a PharmD as well as a PhD from the Choice Institute at the University of Washington. And he has researched and in recent years has really published broadly on assessments of the implementation and effects of academic detailing programs. And he and his colleagues are really moving our shared field forward in the research literature. And so it's especially exciting to have him here to talk about another one of their evaluations. So Mark, let me hand it over to you, and thank you for being here.
Thanks, Mike. I just want to make sure that I'm coming through clearly through my headset. Can everyone hear me okay?
You sure are.
You are,
nice
you sound great. Yep.
Thanks. So thanks for that introduction. And I just wanted to at least establish some backgrounds for how academic detailing is done at the VA. Sarah did a great introduction on bringing at least our program office into the fold of academic detailing. And before I start, there's a couple of disclosure statements that I have to make. One, I'm a federal employee, so everything I say or present today are reflections of my own opinion and not those of the government. Next slide, please. So just to kind of give you some background, before we started, I had a poll question. This is new for me, so thanks, Bevan, for getting me oriented to this. So the question I had,
sure.
Yeah, Bevan, did you want to introduce this question, or do I do that?
Sure, I'm happy to help. So Mark wants to know what you think, back over to your poll everywhere. What are some risk factors of using a benzodiazepine with an opioid? All right, so let's see what we've got. Overdose, respiratory depression, lots of respiratory depression, death, CNS depression, sedation. Yeah, Mark, how does this look in terms of what you would expect? And thank you for someone kicking us off with our first emoji.
I love that emoji. It's a great emoji. This is a line
too.
Yeah, this is a line what I was thinking. What's amazing is that nothing positive about this combination, right? We know as clinicians, and maybe even not as clinicians, non-clinicians, we know that this is a bad combination. It's harmful. There's a lot of potential adverse reactions. And the literature has shown that patients who overdose on an opioid, about 1/3 of them have some type of co-prescribing with benzodiazepine. So this is not only a big public health issue, but it's also a big issue in the VA. I think several years ago, a paper came out from the VA showing that about, I forgot what the numbers exactly were, but the mortality rate was twice as high in the VA for any drug overdose compared to the US population. And part of that has to do with our historical use of opioids and also some of these co-prescribing practices with benzodiazepine. So very, very harmful combination. And as everyone pointed out in the poll, that there's nothing good about this. So what has the VA done since then, since we learned about this in terms of trying to reduce this dangerous co-prescribing? And part of the VA strategy to deal with this was developing several initiatives. The most important one was the opioid safety initiative, because this is one of the biggest public health crises we've faced in the past couple of decades. The VA really established this large national initiative to sort of reduce the amount of unnecessary or dangerous opioid prescribing. They came out with a guideline with the Department of Defense in 2016 to update the pain management guidelines to look at also non-pharmaceutical strategies to deal with pain. But the important thing was dealing with the overutilization of opioids. And around that same time, the Psychotropic Drug Safety Initiative was initiated in 2013. So the PDSI, as we like to call it, was really focused on the utilization of benzodiazepine in a population that may not necessarily need it. So things like PTSD populations, the elderly populations where you may have dangerous, high risk of falls. So those are the type of patients that we're trying to target, as well as patients getting combinations with an opioid. So these initiatives that the VA had created really established a framework from which academic detailing can insert itself and help catalyze some of these initiatives. So we partner with these different initiatives in order to bring an element of academic detailing in order for us to directly interface with the providers and educate them, reducing the knowledge gap, as well as addressing any type of modifiable systematic barriers that we can help them with. So developing online dashboards in order to monitor and track providers prescribing, developing educational tools to help the academic detailers share this information with the providers and the patients, as well as making shared decision-making tools with them. So with these sort of premises established, it's really convenient, I would say, for us to sort of go in there and start evaluating all of these things. And just to kind of orient people to how academic detailing is done in the VA. It's a national program, but we have a program office, which is where I work in. And we help facilitate and also work with our regional academic detailing programs to help sort of spread the message of academic detailing to these different disease areas. And what we provide is this really neat online platform called Salesforce that allows our academic detailer to document their work. So we not only have the electronic health records of the VA, which is very, very powerful, and we can leverage that for all the clinical information, but Salesforce really is the key for how we are able to document and capture the academic detailer's work and interfaces and interactions with the provider. So using these two data sources, we're able to pull these together in order to generate the database that we use in order to analyze these types of interactions as well as associations. So with that being said, I want to dive right into some of the aims we had for this particular project. We do know that opioid utilization has gone down in the VA, as well as benzodiazepine utilization, just because we have a national campaign for these two types of medications. But we really wanted to look at whether or not academic detailing modified or enhanced the rate of those types of reductions. So we developed a study to look at over 54 months, stations or facilities that had implemented academic detailing and compared them to stations that didn't implement academic detailing. We really wanted to see did the slopes change or the rate change over time. And the other thing that we were interested in was whether or not the number of providers or proportion of providers that were detailed at a particular station also influenced the rate of reduction in the opioid benzo prescribing. So just to kind of give a little background on that, why we did that is when we rolled out academic detailing across the nation, it wasn't a one-time event. This took several years to do. So as you can imagine, you had this heterogeneity of rollout or implementation across the field. Some stations implemented academic detailing early and they reached a lot of providers early on. Some stations took their time to implement academic detailing and not a lot of providers were exposed to academic detailing. So we wanted to really study whether or not the proportion of providers that were actually exposed to academic detailing had any type of effect on the rate of decline over time. So this table provides some descriptive analysis of the different types of stations we looked at. So we looked at stations that had implemented academic detailing, and we had about 130 stations in the VA altogether. And these stations represent a sort of cluster of medical centers and outpatient clinics that are sort of nested within these stations. And we had stations that didn't implement academic detailing. As you can see, the numbers for the control group, or in this case, the stations that didn't implement academic detailing is quite small. And that kind of gives you an idea of how influential academic detailing has been in terms of its reach and spread across the VA. But as you can see, a lot of these characteristics are very similar in terms of the number of monthly unique outpatient visits we had, the number of unique inpatient visits we had, and even the number of unique pharmacy patients we've had. So not too much differences in some of the key parameters when we looked at these types of activities or productivities at each of the divisions or the stations. And even the divisions are sort of nicely spread out because of the small sample size for the control groups. We didn't have any in the Southeast or continental areas, but for the North Atlantic, the Midwest, as well as the continental, or the Pacific, we had some relatively stable numbers there. Next slide, please. Now, this slide represents a couple of things. There's two dimensions to this slide. One, we wanted to look at the rate of decline for benzo and opioid combinations in the natural state of the VA. As you can see, that's the dotted red line. And we see that there's a decrease in opioid benzo prescribing. And that's not a surprise to us, right? Because we had initiated the opioid safety initiative, and we had initiated the psychotropic drug safety initiative. So these are something that we would expect to see over time. But what's also interesting is that the proportion of providers that got exposed to academic detailing also increased during this time frame. So it led us to naturally ask the question, how does this proportional increase in providers over time also influence or accelerated the increase in the rate of decline for the opioid benzo co-prescribing? And next slide, please. And here are some answers. So we have two lines here. The blue line represents facilities or stations that had implemented academic detailing, and the red dotted line represents stations that had not implemented academic detailing. But as you can see, they both decline, which is good because this is what the VA really expected to see. We wanted to see a decrease in the prevalence of this dangerous opioid benzodiazepine combination. But what this graph also shows is that the blue line actually has a much steeper rate of decline, which is really nice to see because it tells us that the sites that implemented academic detailing somehow modified or accelerated or even enhanced the what the VA is already doing, right? So you have this sort of catalyst of an effect here, and you see that the rate of decline is significantly greater than the rate of decline among stations that had not implemented academic detailing. Next slide, please. So what do we conclude from this? One, we know that academic detailing had an impact on the rate of decline for the prevalence of opiate benzo co-prescribing. And this potentially can lead to a reduction in the risk of opioid overdose events. At least that's what we hypothesize. So this really aligns with a lot of the other studies we've done in the past. We've showed studies where we've reduced high dose opioid utilization. We've also showed studies where we actually had reduction in benzodiazepine. So it's really nice that we can see this sort of reflected in this opiate benzo combination that we were looking at in this particular analysis. So just to kind of give a little background on what we've done in the past, Addison Reagan and Vision 7 down in the Southeast did a really nice study where they looked at benzodiazepine prescribing among patients that were elderly. And in the VA, we had defined that as 70 years or older in this particular cohort. And they showed that at providers, this is a provider level analysis, when they were actually, when they received academic detailing, their patient population and the elderly had a much greater reduction in the number of benzodiazepine prescriptions that were being prescribed. And this is in comparison to a similar cohort of providers that had not received academic detailing. And in a separate study that we did at the program office, we looked at the national population of providers in the VA to see whether or not benzodiazepine prescribing was different among providers that received academic detailing, specifically for PTSD populations. And we saw that those providers had a much greater reduction in the prevalence of inappropriate benzodiazepine prescribing relative to providers that didn't receive academic detailing. So it's nice that we saw that there's some consistency in the rate of the reduction in benzodiazepine, along with our own rate of reduction, our opioid benzodiazepine combination analysis. But with that being said, there are always limitations with our type of analysis. And one, we want to highlight that this analysis on the opioid benzo prescribing was done at the station level as opposed to the provider level or patient level analysis, as most commonly done in our program office. And the reason for that is because it's really hard to identify a patient that receives an opioid and benzo from the same provider, because a lot of times these prescriptions are actually prescribed by different providers, not only just in the VA, but also in the community. So we had to think about a way where we can see these combinations So in the literature, if you read the literature, there's a lot of different definitions of what combinations really mean. Is it a 1-day overlap, a 5-day overlap? So we went with a more sensitive definition of a 1-day overlap from different providers. So the only way to really look at that from a national level was to look at it from a station level. So we looked at station level analysis to see whether the patients at these stations got a combination based on a 1-day overlap. And then the other thing that was interesting was that the VA also had other efforts that were going on, right? So we never want to say that academic detailing was the only thing that caused the reduction in opiate benzo prescribing. We have to consider all these national initiatives that are occurring. So this nicely aligns what we expected to see is that we saw a reduction in the control group because of the national initiatives, but we also saw the enhancement of academic detailing on these experimental groups or the exposure groups, because you saw the reduction in the decline was much greater in that population. Okay. So now that we've done this study and we're going through peer review, I kind of want to ask the audience, what other data do you think we should have collected or should collect in the future?
All right, looks like we have qualitative data around provider response, some of that good narrative data. Data on PDMP utilization, med dosages, prescriber reactions again. Yep. Peer review utilization, overdose rates, consent. That's interesting. Mike, do these sort of match some of the things that you all have been thinking about? Prescriber satisfaction, MMEs?
Yeah, I really like how people are pointing out the clinical endpoint of overdose rates. That's something that we as a national, not as a program officer, but nationally are trying to get a much more accurate data on. So we're working on that right now, especially with Elizabeth Oliva and some of the Program Evaluation Resource Center group, PERC, in Palo Alto. They're working to develop a better way to sort of monitor the overdose rates, because a lot of times these are not always captured in the VA electronic records. They have to be self-reported, or if they survive, they report it. We're able to capture it that way. So documentation is going to be important for that. But the MME part, I think that's good because we do have a paper in peer review looking at MME reduction over time. So hopefully that comes out soon.
Great. And Mark, already starting to get lots of questions in the chat box. So I'm going to throw this back to you to share your conclusions, and then we'll do some chat box questions. So keep them coming, everybody.
Yeah, so some conclusions that at least we can make based on our analysis is that academic detailing has a role in reducing the harmful combination of opiate and benzo prescribing. And one of the things that was interesting was that you saw the increase, and I'm sorry I didn't really spend more time on this, but we did another analysis. We looked at the relationship between sites that had increased the proportion of providers versus sites that had not really increased proportion of providers. And we saw that there were significant differences there in terms of the reduction of opiate benzo co-prescribing. And really the proportion of providers that are sort of receiving academic detailing represents a type of implementation science evaluation, because we're looking at implementation reach here. And another way to think of this is sort of penetration of our intervention across the nation. So just kind of measuring that implementation reach allows us to create some narrative about how sites that had implemented it early had benefited the most. And there's a lot of optimization you can do with implementation reach. And of course, using the proportion of providers allows us to be very flexible in determining another new metric, right, for implementation, so that we can also monitor implementation while we're also looking at some of the endpoints that are in our particular analysis.
Awesome, thanks, Mark. And I'm going to breeze through your reference slides so that we have time for questions. But everybody, we will have a full recording of all of our main sessions as well as the slide decks up in the coming days. So you'll get to look at this with a little bit more of an eye for detail and all of the great people that were part of Mark's team. So over to Q&A, and want to let folks know I've been getting little messages that I so appreciate to keep me on my toes. For fairness, if I go in a different order with the chat questions than they appear, I may get the quick ones out of the way first. So don't worry, I'll try to get as many as I can. The first one I'm going to ask is a quick one from Lena Salak from CEP in Canada. What were the timelines from launch of visit to the data pull? What was that period of time, Mark?
So I believe we went, so it was about 54 months. I believe it was from 2014 to 2017. So including, yeah, but those 4 years, we actually included data from those periods. So early on in terms of when the initiatives began, and all the way up to the most complete data that we had at the time we did this evaluation.
Awesome, thanks, Mark. Quick question from Alona Balsanova. Hi, Alona. Is the benzo tapering document from the VA widely available? And I'm going to connect that with Anna Gribble from Maryland's question. Has the VA's AD program incorporated your benzo tapering resource? Any lessons around that? So all about that resource, Mark. What can you tell us?
Yeah, I don't know if I can provide a lot of feedback on this because I didn't really develop those educational tools, but we do have them on our internal website. I don't know if they're available on the public website. I'll have to double check. I don't think they may be, but we do get questions from the public a lot of times. Sometimes we get public questions from the education department from different states asking us for access to our resources. And because we are a VA in the federal domain, these should be publicly available. So we do share them with them. And there are times where they actually modify it or they adapt it for their own population. So we do allow that. We just ask that they make sure any changes they make, they attribute it to them, their own changes, but they also maintain the master document that we created. I don't know, Melissa, do you have anything else you wanted to add?
Yeah, we do try to keep all of our newest materials up to date on our public site. And the benzos have been a topic that we've been doing for some time now. And so they are available in our catalog, and we're continuing to add new documents there. They're actually up for revision. So we're in the process of revising that tool further. And I think it's been a great partnership with our Psychotropic Drug Safety Initiative. We work very closely with Ilse Wiekers, who's been leading that over the last several years with us. And that's been a place where the connections have been very strong with our mental health providers. I think a lot of benzo changes are conducted by our psychiatrists, but not only. I think primary care is involved with that. But it's been a great partnership to really do those learning collaboratives with her. While the academic detailers are working one-on-one with clinicians, those collaboratives have been a great source of support as well on the benzo topic, because it is complex to change patients' medications, both looking at the opioids and benzos.
Thanks, Melissa. Really appreciate that. And thank you, Dana, for sharing that link. Again, folks, if you're worried about catching everything, we're going to save the chat and make sure all the great resources that are being shared are up on our conference archive. We did have one more question from Todd Lee in Chicago, but Todd, I'm going to table that and make sure it gets bounced over to Mark via email. So thanks for your patience there. Want to make sure we have plenty of time for our next presentation. Thank you so much, Mark, for being a steady presenter of such great data every year. We really appreciate you and all the great work that the VA continues to do. So thank you. Next up, we have Nate Rickles from Connecticut, who we are super excited to turn the mic over to discuss the ways in which Connecticut pharmacies were integral to a referral program for promoting women's health. I'm going to let Mike introduce Nate, and then I'll turn it over to you, Nate.
Yeah, so it's really a pleasure for me to have a chance to introduce Nate, because he's come to our conference on and off into various NaRCAD sessions going back quite a number of years now, and really brings a terrific perspective to it. He's a PharmD and PhD, so a double doctor who's done pharmacy practice residency and maintains his board certification, and also is a fellow of the American Pharmacists Association. But he's been researching how to develop, implement, and evaluate intervention programs that really look at the role of the pharmacist in innovative ways, improving their communication with patients or with other team members, focusing on medication adherence, patient safety. Really important work, reimagining and expanding the role of the pharmacist, but doing it with from the perspective of an active researcher who really brings a rigorous lens to those questions. So really thrilled that he's coming, or not coming, because no one's coming in. We're really thrilled that he is joining virtually today to tell us about this program of theirs.
All right, Nate, let's do this thing. Over to you.
Thank you so much, Mike and Bevan. So yeah, today I'm excited presenting on engaging Connecticut pharmacies to a screening and referral program to promote women's health. And I have no conflicts of interest to report, but as was suggested before, I am a state employee, and I do want to make sure that you know that today's comments are reflecting myself and not the state of Connecticut. The project was supported by the CDC, and we thank the CDC for its support. And so let's talk a little bit about this program. So the Connecticut Early Detection and Prevention Program is basically a combination of two programs. One, the Connecticut Breast and Cervical Cancer Detection Program, as well as the Wise Woman Program. And the Wise Woman Program is in particular that we are focusing on is cardiovascular risk reduction and healthy heart lifestyle. So you see here with the objective, it's to significantly increase the number of women who receive cardiovascular, breast and cervical cancer screening, diagnostic and treatment referral services. Next slide, please. So on this slide, you get to see all the wonderful services that are provided free to these women who enroll in this combined program. And you see here, you know, there's office visits, and you see all the way down to cardiovascular screening, HPV screening. One thing I just want to draw your attention to that's unique about Connecticut's program is the medication therapy management. So we have two components to this grant from the CDC. One is medication therapy management, and the other one is this use of academic detailing to increase the screening and referral of women into the program. So I just wanted to bring that up at this moment. Okay, next slide. So this is one of the promotional pieces that the program has developed, and I give credit to DPH for helping develop this. So here hits home the key points about the fact that in recent years, Connecticut has been the second highest incidence of breast cancer in the United States. 38,000 women in Connecticut are not receiving health care, and they largely because they don't have proper health insurance. And over 4,700 women in Connecticut died from heart disease in 2015. So again, these numbers are something that we really need to address and manage. Okay, so the next slide kind of highlights the need for this academic detailing program. As Mike mentioned early on in introducing this segment, we're really trying to move the needle with health disparities. And in this case, it's among women who are low income, underinsured, or uninsured. This may be due to a lack of access to preventative services. I also should note that many of these women are not legally present, so to speak. So they are women who don't have access to health insurance because of their citizenship status. Many clinicians lack awareness of the programs and do not offer such opportunities, so they don't know about it. So our role is to help them to get to know about it. Limited data on the role of pharmacists in aiding the screening and referral of vulnerable populations. I bring this up because I think pharmacists could really increase their role in screening and referral of many programs. This is just one example, and I think that this will be a great opportunity for the future. So what are our goals? To determine if pharmacies, and university-based academic detailing increases referrals to a free public health prevention program for vulnerable populations. Conducted evidence-based academic detailing training program for pharmacist detailers to provide visits to community pharmacists. So again, this is trying to train a few pharmacists in going to pharmacies and saying, hey, if you see women that are there, try to reach out to them and see if they would be interested in this program. So that's where we trained 5 pharmacists on academic detailing techniques. And we're very honored to have the consultant, Dr. Amanda Kennedy, who I'm not sure if is here today, but she was a great resource for us as well.
She is attending our conference, so we're lucky to have her. And thank you, Amanda, for being part of this project.
Thank you, Amanda. And Amanda provided some initial conversation about how to deal with some of the hurdles that our newbie pharmacists were going to potentially encounter. So there's three brief visits that are the focus of the intervention. These are where the community pharmacists, once they're trained, they're going to make three roughly 20-minute visits. We knew it had to be brief. We know that academic detailing is at its best as brief. So that's why we made sure that the pharmacists that were trained understood that. Plus, keep in mind, community pharmacists are very busy. They don't have a lot of time. Maybe it's just during a lunch hour, or maybe it's at the end of a shift. And then also we recognize the need for structure and as much structure as possible. So the use of an action plan, a checklist to ensure the delivery of key concepts, just so that they can check off the points that they needed to cover. We also recognize the need to have an incentive. Continuing education was a really powerful incentive. So they actually, I think the pharmacists were interested in that. And then also a referral payment. So if you indeed refer a woman to a Wise Woman site, you will get a fee. And we'll talk a little bit about the challenges of that. So the goals for the detailers when they made visits there were several. One was to discuss the benefits of referring patients to the Connecticut Early Detection Prevention Program. And keep in mind, this was objectives that all 5 of these objectives were listed on the action plan. We also wanted the detailer to describe the eligibility criteria for the patient population, describe the screening and referral process for identifying participants. So these are the criteria for determining if a woman would be eligible for the Wise Woman program, or I should say actually the CEDPP program as a whole. Identify the presence of individual and pharmacy level facilitators and barriers. So the detailers were to document these facilitators and barriers so that they can use this as a basis to design an action plan to begin and sustain screening and referral to the program, by the pharmacist. So here's some program materials. Think about it. Here these detailers go to pharmacies. Many times they're going to interact with staff pharmacists. They may interact with the pharmacy owner, but you really need to have. And so they included a letter of introduction to the pharmacy owner or manager. There was also, and by the way, all of this was put together in a packet. And these packets included this letter, a promotional poster, a fact sheet about the program, a patient referral form that included the eligibility criteria on it. So again, the pharmacist could check off that they covered certain criteria so that when we referred the patient, we knew that they met those criteria. We also included a referral tracker so that they could actually document who they referred so that we can capture that information later on. Also, an academic detailing action plan, which literally was about 3 to 4 pages of statements. And it was visit 1, visit 2, visit 3, where they checked off which visit they covered the different points. They didn't have to cover all of them during the first visit. In fact, they were given suggestions to cover certain points during a particular visit and then during the second visit. I have to say that many of the detailers were actually able to cover most of the points within the first 2 visits. We provided everybody a flash drive in case they wanted to print more materials out, and continuing education instructions. Now, I made sure that detailers did not give that to the pharmacists they were detailing until they finished the program. Because obviously if they got the CE credit information, they might not complete the program. So that was a little bit of a carrot. You need to be present for all these visits to get your CE. And this was pharmacy CE, I should add as well. So during visit 1, they provided a letter to the pharmacy owner, manager. They reviewed the target goals. If they got interest from the detailer, they made sure they scheduled the visit 2. And they would also cover certain points that they had time to cover. Really keep in mind, first visit was a lot about talking about the benefits of the program. Okay, so the next visit again was to continue to cover some objectives, the other objectives we talked about. Also, there was a part of the action plan where they were to indicate the extent to which the detailer covered certain goals. So, you know, did they achieve certain objectives and when did they achieve them? And again, they explained the process of the referral process and really tried to make sure that they could get the detailed pharmacy to identify a screening process that worked well for their pharmacy. Again, also exploring barriers and facilitators. Okay, and then Schedule 3 if it was necessary. All right, next slide. So hopefully by visit 3, all the goals were covered. They have achieved all the target goals. They got their CE instructions. And they also completed an evaluation of the program, which by the way, they completed online, not in front of the detailer. And they actually went online, and that's actually how they also got their CE credit. And the action plan was sent to us. So I have many examples of action plans. So this is just a quick slide to show you that one of our pharmacies really went the mile and presented it out on their screen up in Bridgeport, Connecticut. So that was kind of cool that they used some electronic screen space on the roadside. And then you see an example of one of our detailers talking about the detailing method. Okay, next slide, please. So there were many challenges, you know, figuring out what would work for the pharmacist in terms of scheduling and how much time they had. But that was actually only a small part of our challenge. I think, interestingly enough, we learned a lot about the challenge of pharmacists getting referrals, incentives. So some of them said, well, the pharmacist should get the referrals. Others said the pharmacy should get the referral. So there was a little bit of a challenge around that. And then also COVID-19, as many know, presented some challenges for face-to-face visits. So we changed to virtual visits. And by the way, I highly recommend the NaRCAD modules on the virtual academic detailing. Very useful. And I actually gave that to all of my detailers. So what we pivoted a little bit by using lists of patients, again, de-identified of health information, but basically identifying women on behalf of the pharmacy. You know, so I have students, a cadre of maybe 5, 6 students that actually call these women and screen them and determine if they're eligible. And we actually were able to pivot with a Spanish-speaking student, and she has really knocked it out of the ballpark and really gotten a number of Latinx women who would have otherwise not gotten screened. So again, we are directly promoting the program to sites, organizations across the state of Connecticut, and you'll see on the next, and you'll see that also on the future slide. But here, we've contacted 125. This is for the face-to-face visits and a little bit of virtual. But essentially, you can see how many different visits and how many referrals were made. And here in this slide, you see that essentially we have doubled. I mean, we're still in our infancy of our screening program, but you can see how getting it from our lists, from student-led efforts, has doubled our successful enrollment. So that's been exciting. So here, this is our effort with promoting it across the state with flyers and emails and so forth. So you can see we've been busy with promoting the program across the state. And let's see. So in terms of current and future directions, we're having the detailer actually using their expertise in supporting in the School of Pharmacy student callers and referrals and making sure, helping them to troubleshoot what kinds of problems are coming up along with my oversight, using the bilingual students to facilitate referrals. By the way, we have our script in Spanish, everything completely in Spanish available for that piece. Creating more clarity on screening criteria. Believe it or not, a number of women didn't understand what it meant not to have health insurance or not to have full health insurance. So we had to add that to our screening criteria. So we learned a lot from that. Also, one of our detailers is really a phenomenal promoter and salesperson, if you will. And really, we want her to role play what it is to get a pharmacist motivated to screen and refer. And then we're also looking to review more of the CE evaluations because we really want to know how our detailers are doing out in practice. So we have that feedback. This is not, I'm not going to go over this in any great detail, but understand that we had process flows that we shared with all of our detailers. Say it goes from this person to this person, and this is how the referral should happen. And this is just one example. We actually have a process flow for the detailer, for us, and for all the people that are involved. So everybody understands the steps involved in the process. And I think—
All right, it's poll time. Yep.
I moved as fast as I could.
No, you did a great job. Not to worry. No, we'll make sure that if there are additional questions for all three of this morning's presenters, that we'll do those on the chat and follow up. So not to rush, Nate. All right, Nate has a great question here. So pop on over to your poll everywhere. Why would underserved women such as those that Nate, described as the target population, why would they not want to participate in this free program? So what are the barriers? Fear of ICE, yep, immigration worries, affordability, language, misunderstanding the program, lots of fear popping up, affordability, stigma, fear of surprise bills. Wow, so much stuff here, privacy concerns. Nate, do these sort of ring true with what you and your colleagues thought about as potential barriers?
Yeah, and I think one of the first ones there that really was informative was around the concern around citizenship status. The women actually asked our detailers, am I going to be reported? And that's something very real and very serious. And once they found out that we're not reporting them to any authority, they actually opened up, and several women have asked to be involved in the program. So that was really important. And I think that was important, a critical piece for us.
And just to say really quickly, Nate, I know that when you and I talked about this presentation in advance, transportation was a big piece too. So sometimes wanting to do it and not being able to do it seemed like a big piece of it. And I see that somebody hit on that as well. So moving over to solutions, Nate wants to know, what do you think some solutions to the pieces that you all just brought up and hit such a great, diversity of these challenges for these women? What could be some sort of starting point solutions for things everywhere from fear, health literacy, language issues, to things like transportation and stigma? All right, so we have providing vouchers for transportation. Yes, community health workers, public health awareness, translators, free healthcare for all. Yes, we can dream big. We can dream big. Concerns in marketing, navigators to assist from step to step. Absolutely. Yeah, so you guys have a lot of awesome solutions, ideas. Nate, how do these seem to you? Yes, providing childcare. That's a beautiful one.
Actually, that's a great idea. I like that a lot.
Yeah.
But by the way, so the transportation was a big concern. Keep in mind, one thing I really didn't touch on, but when we referred people to the Wise Woman sites, they were referred to a navigator. So they actually, that navigator helped to, if they confirmed that they were eligible, that navigator was really critical.
Thanks, Nate. And just to make a quick note, 2 people just texted getting a new president. Excellent. All right. Well, we've checked that off. So now over to some Q&A. For those of you who still have Q&A for Mark or Sarah, please go ahead and type it in the chat box and they'll be able to get back to you, or we'll triage your question to them later in the day. But for Nate, we have a couple questions here, one from Jackie Travers and Julie Fitch. Did you see any difference between the response from independent pharmacies versus chain pharmacies? A great question. What do you think, Nate?
It's an awesome question. So our success was really with independent pharmacies. It's not to say there was a few CVS's and Walgreens, to name a couple of the chains, that were interested, but there's just hurdles, making sure that corporations are comfortable with what's being done. But they were open to it. I think we just have to hit that a little bit harder and make greater efforts in that area. I will say that one sort of, you wouldn't call it a chain, but ShopRite was very interested, and they actually are the source of a few detailed sites.
Awesome. Thanks, Nate. And a couple more nuances to this question. So we have Joanna Bucks-Kemper shared that there are more time pressures for those practicing in a chain environment. So that's probably part of the challenge, is time as a resource. And then wondering what you think about Latanya Rice's question about, was there any rejection from chains that wouldn't allow these types of meetings?
Yeah, there weren't any flat out rejections. Nobody said no. I mean, of course, when you come to them about women's health and trying to advance women's health, it's an important topic, and they saw this as being a great service for their patients. I just think that taking their time out and their corporate time, if you will, of how does it work with the workflow. I think this could be done on when there's overlap in shift or things like that. So you just have to really, I think, hold their hand a little bit. I think it's still doable. And actually when I look at the growth of this program, I think it's actually going to the chains and doing it in baby steps.
Awesome. Awesome. Yes. And what I love so much about what you've shared from your campaign, Nate, is how responsive to these challenges you were in real time within the period of implementation. So that's really terrific. I know that our very own Mike has his own question that he's prepared for you all. So let's wrap up with that one, and then we'll let you know how lunch is going to work and the rest of the afternoon. Mike, over to you.
Awesome. Nate, this is terrific. Thank you. I'm really intrigued by how this worked and the broad range of issues you got into. It does, as you mentioned, really tie back to some of the themes we were talking about earlier. And I wonder if you can just reflect for a moment on whether there are other sites that can act in the way that the pharmacies did here. In other words, once you're getting out of the medical office setting, there are all kinds of places we can interact with patients and broaden our lens. Could you imagine an intervention like this being done in other settings in addition to the pharmacy?
Absolutely. In fact, I would hope that's the dream, because I just viewed pharmacies as so accessible and available. So what I would hope is that it would be done in other settings where it can actually improve access to this kind of information and these kinds of referrals. So absolutely, it could be in community health centers. It could be, I just would love to see the big push in primary care.
Awesome. Thanks, Nate. And thanks to you all for the great comments in the chat box. We've had multiple folks say that all three of these presentations were extremely helpful, really exciting to see this innovation. So believe it or not, we are on time. It's 12:30. I am amazed with us, and thanks for helping us stay on time. All right, so here's what's up for the lunch break. Come on back just a minute before 1 o'clock so that you can pick your breakout session. So stay logged into Zoom, and then when you're ready to pick your breakout session, which Anna is about to drop the information about into the chat box, you're gonna go to either the links in the chat box to pick one of the three, or you can go to narcad.org/breakouts, and you'll see a description for each breakout and the link. They'll begin right at 1 o'clock. So you can either sign in now and just put your screen off until 1, or you can hang out in here and switch at 1. Doesn't matter. But you'll see from Anna, we have our AD 101 breakout featuring Todd Lee of Chicago and Zach Dumont from Regina, Saskatchewan. We have the storytelling breakout with Jackie Travers and her colleague Reagan. And then we also have the Build a Brand breakout, which is from our partners, Shirag Rathod and his colleague Michelle. Again, you can click on the link and learn more at narcad.org/breakouts. Thanks for a great morning session. Go have yourself a great lunch, and we'll see you in a half an hour. All right. Thanks, everybody. Thanks for a great morning session. See you soon.
Breakouts will not be recorded, to answer the question that was in.
Yes, yep. No recording on the breakout.
So you can say whatever you want.
Say whatever you want. It's like you owe me a Coke. All right. See you guys in a bit. And feel free to put your videos on pause if you don't want us to see your cats or your tuna fish sandwich. Take care. super excited to see those of you who came back from the breakout looking pretty fresh, pretty enthusiastic. We look forward to hearing your comments about your specific breakout groups on our evaluations at the end of today. To try to make filling out an evaluation something that sounds fun, although I know some of you who are very much into data will know this is very important. But for those of you who are not particularly excited about evals, I'll tell you two things to make it fun. Three things actually. One is it's pretty short. Two is that we'll give you time during the conference to fill it out. Three is that all of you who fill it out and are willing to leave us your name, we will enter you into a raffle to be chosen to apply $50 from us towards a list of public health charities who are combating COVID, opioid crisis, and so forth. And there'll be one person drawn per day. So hopefully that's enough incentive. I think at the conference in person, we usually had other sundry items that may seem exciting, but I think this is more exciting, unless you are missing out on pins, keychains, what are those called? Pop sockets. Those are pretty fun. Next year, we promise we will have fun things. Looking at NaRCAD M&Ms because public health. All right, so I think we have everybody back. I am so excited to turn the mic to Mike to kick us off in just a minute. But first things first, I am going to ask all of you to remember to put your camera on if you can, because we're going to have some more discussion. And I'm going to refresh those of you who have already done Poll Everywhere as of this morning. You should be all set. If you come up with a message when you do our next Poll Everywhere that says that it's not working, it just means you need to sign back in. So same thing, you'll want to text 22333. Excuse me, text NaRCAD 1108 to 22333. For those of you who are new to our afternoon session, please go ahead, grab your cellular device and set this up so that we can pop right into a poll that will set the stage for our upcoming plenary on AD in long-term care settings, deprescribing to improve quality of life. And we're sure that for those of you who are not working on interventions that focus on elderly and related vulnerable populations, who will also be focusing on other vulnerable populations, that there'll be some translatable points here. All right, very excited. Let's see if we can go ahead and kick off our last Poll Everywhere. Oops, somebody tested it. All right, thank you for testing. Name a challenge that clinicians who work in long-term care face. Somebody kicked us off with polypharmacy. Excellent. What else do they face? All right, we have so many awesome things here. Dealing with family members, yes. Volume of patients, being off-site, burnout, 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 end-of-life care, high turnover, funding cuts. Oh my goodness, yes. Communication issues, increasingly sick patients in long-term care, staffing, bingo. Yes, bingo is a problem. I'm sure there's somebody working on a key message for that. Thank you for the levity. Reimbursement, repetitiveness, lack of desire to change therapy. Yes, again, short staffing. All right, treating ailments versus prevention, right, end-of-life care, etc. Okay, we've got a lot of similar themes here. And without further ado, I am going to turn it over to Mike, who will sort of set the stage for the fact that this session will be really impactful as we discuss how AD can help overcome some of these challenges in ways that are realistic. So I'm going to turn it to Mike to introduce Dr. Justin Turner. Thanks, Mike.
All right. Welcome back, everyone. As we come towards the last session of the first day, really appreciate the engagement. I had a great deal of fun in the breakout session that I was in, and hopefully all of you did as well. And just since it wasn't in the group format, I do want to thank our 6 breakout session moderators for their willingness to not just to do their breakouts, but to adapt them to this this new format that we've all ended up in 2020. So thank you, all of you, for what you do. And I know that the participants in each of your sessions appreciated it. So, so as Bevan said, this is one of the really vulnerable patients, and I'm particularly intrigued by this session because it goes back to some of the initial academic detailing. So if we look at the very first academic detailing study, and I mentioned this very much in passing in the morning. Jerry and his colleagues did the first study in outpatient settings in 4 different US states back in the late 70s, early 80s. The second study in the 1980s was done in a group of 12 nursing homes in long-term care, and was focused on academic detailing to reduce the prescribing of psychoactive drugs. And you can find that paper on the NaRCAD website, and I won't go into it here. But even then, from the very beginning, there was a recognition of the challenges, and you all highlighted them, that you have with medication use in the long-term care setting, and a hope, and it was certainly borne out in that first study, that academic detailing has something to offer in terms of making that situation better. And so the challenge for all of us, and where the innovation that we're going to be talking about over the next hour is so exciting, is to keep thinking about how do we build on that initial study and adapt and update and customize it to current settings where there are a lot of different pressures in the long-term care setting. The dynamics of many elements of care and medication use are different than they were 35 or so years ago, although I would suggest that we can draw on some of the same underlying principles. So that's one element. The other piece is the concept of deprescribing, which is one we've heard about. It's sort of been coming up through our networking activities more and more. Given the expertise of our speakers over the next hour, I'm not going to try to define it. I'm excited for these experts to walk us through the concept and to help engage all of us in thinking about it. This is a session where I really, I already, since I had a chance to have a sneak peek at all of their slides, have a lot of thoughts and questions, and I hope all of you will as well, that we'll have time for a really robust discussion here. To get us kicked off, we're going to have the stage set and some framing provided for these concepts by Dr. Turner, and then he'll then hand it over to Dr. Jennifer Pruskowski, who's going to take us through a case study of a specific intervention that I think will make concrete a lot of the concepts we're talking about. So to begin with Dr. Turner, Justin Turner, he's a researcher. He's a pharmacist who originally practiced in multiple different settings in Australia, including long-term care, but also in hospitals and the communities. Both in Australia and the UK. He, as he said in his bio, he moved to Canada in 2015 searching for snow, and I would certainly anticipate that he's found that. But he's also been thinking about really important questions about how we improve medication use in older adults. And the Canadian Deprescribing Network, which he's the co-director of, has become an important and influential voice across not just Canada, but across North America and really the entire global research community, striving to figure out, how do we use medications more rationally? How do we avoid some of the problems of polypharmacy that some of you put into the word cloud just a minute ago, in ways that are evidence-based, safe, and beneficial to patients? And so that's why we're so excited to have Justin Turner here to begin this afternoon session by walking us through the impact of academic detailing on deprescribing in the nursing home. Justin, over to you.
Wow, what an introduction. Thanks, Mike. And I'm so excited to be here. Disappointed it's virtual, but that is the new world order. And I'm super excited to see a presentation on academic detailing in nursing homes. It seems like it's gone full circle. That's definitely where I started. I have nothing to disclose, which is great. And apart from, I'm very excited to be coming up to introduce Jennifer Pruskowski and hear her pilot project. I guess when I start talking about deprescribing as the director of the Canadian Deprescribing Network, I always put this slide in first to say medications are really important. We need them to treat symptoms like reflux. We need them to reduce harm from chronic diseases like diabetes. And, goes without saying, to reduce mortality from things like cardiovascular disease, where mortality now is so much lower than it was before. However, when I consider, thank you, I'm pushing the button, of course, it doesn't work here.
I got you.
Thanks, Evan. When I'm considering, a little bit of medication is great, but what if we have more? Well, too much of a good thing is not great. And this is a quote from Chris Freeman, who was the president of the Pharmaceutical Society in Australia, who said, if medication harm was a chronic disease, it would already be a national health priority. But that was Australia last year. What about the US? This slide from the Loan Institute last year says medication overload is America's other drug problem. We know about opioids, we know about street drugs, but are we really focused on medication overload? And why is this important? So next slide. This year they brought out in January an update for a national action plan of how to eliminate medication overload. And the next slide really shows a couple of key points from there, which I find personally really startling. One is that 5 million older adults in the US sought medical attention because they had side effects or adverse drug events from their medications. On the right-hand side there, we've got 750 older adults are hospitalized every single day. If we think of that in terms of how many people fit on a plane, how many plane loads of people are hospitalized every day because of side effects? And in 10 years, $62 billion was spent on unnecessary hospitalizations. Imagine if we could have put that money into preventing it or into strategies like academic detailing to make things better. Now, not all medications are created equal. Back in the early 90s, Dr. Beer in the US from the American Geriatric Society came up with a list of medicines that said, hey, some of these are probably inappropriate in older adults. So that was 30 years ago. You'd expect by now we might have learned more. Well, not really. As the slide there shows, about 40% of older adults in Canada use inappropriate medications. It costs the Canadian government $420 million a year just in the cost of these pills, and it's $1.4 billion in hospitalization. So in 30 years, have we got better? No. Inappropriate medication use continues to increase. Now this slide is busy and I apologize. Essentially, it's showing a timeline from 2011 on the bottom across to 2019. And on the y-axis, we have how many older adults are chronic users of proton pump inhibitors or reflux medication for longer than they should be. And you see, if we pick on the top line in New Brunswick, about 1 in 5 people were 10 years ago. And now about 1 in 3 older adults continues to use these medications long beyond they've got any benefit. So obviously we haven't learned. But what can we do next? Now this slide, I'll give due credit to Mike Steinman, an amazing geriatrician down in San Fran, who put this slide together for a talk we gave last year. He said, the evidence we have for deprescribing is structured medication reviews, particularly when they're pharmacist-led and followed a structure, are great at deprescribing. If you provide a plan, generally a written plan for how to deal with rebound symptoms or how to taper, we know that we can improve deprescribing success. The farm-to-farm study in Hawaii was a great example where clear communication between hospital and primary care pharmacists limited hospital admissions due to medication side effects. And the last point there, we've got education from University of Montreal, where I am the Empower trial, direct education to patients, reduced benzodiazepines by 27%, but also education for clinicians. But when I was preparing this talk, I thought, what about academic detailing? That's not on the list of really great successful interventions we have. So I was super excited when I got the invitation to come here today, because this is a talk where I'm so excited that Jennifer Preskowski, I knew I was going to get that wrong, sorry Jen, is able to talk to us about academic detailing in long-term care settings and what is the magic that makes it work. So with that, I'd like to hand over to Jen.
Thanks, Justin. And hey, everybody, thanks for having me today. I hope we'll have a little bit of fun for the next 30 minutes or so. And I'm here to give you a pilot example of how to use academic detailing to support deprescribing in the nursing home. Go ahead, Evan. I don't have any relationships to disclose or conflicts of interest to declare. However, this is when I say that my life's goal is to one day change this slide to say that I had a drug company fund a deprescribing talk. That's my life mission. So wish me luck on that one. And I'll also mention here that I am not an academic detailing expert. I really hope to learn from all of you of how you would do this a little bit differently, given the opportunity to join this project. My area of expertise has really been in the development, the dissemination, and implementation of deprescribing in this setting. So that's what I'm going to lean on. That's my area of expertise. And so we'll kind of go from there. Okay, we'll see where we are. So essentially, as Justin just said so eloquently, we all know that we live today in the age of medication overload. Studies suggest that up to 97% of nursing home residents experience some harm from what we call potentially inappropriate or unnecessary medication use. This is also called polypharmacy. Everybody has their own definitions for it. The real problem, though, as Justin just mentioned, is that these medications often cause more harm than good. And listed on the slide, you can see are some of the harms these medications can cause. I'll also mention here, because we've talked about this briefly already, is that these potentially inappropriate or unnecessary medications also contribute to a person's quality of life. It also contributes to a health system's ability to work efficiently. Specifically in the nursing home, you can think about how much time it takes a nurse to give out medications. You know, could that time be used in a different way to spend time with these residents, especially now during the time of COVID, where I can't have families come and see my residents, which of course breaks my heart. And of course, also cost. Not only are we paying for the physical cost of these medications, but we're paying for these events that are subsequently occurring. And again, the time it takes for everybody to take a look at these meds and change them, et cetera. So deprescribing, of course, is the kind of gold standard now, right? It's the solution to this. And while there are many different definitions of deprescribing, I'm going to refer to the definition that has been brought forward by Ian, Scott, and colleagues. Justin knows very well, the group out of Australia. And we're going to define deprescribing as the systematic process of identifying and discontinuing medications, essentially when that risk-benefit ratio does not make sense for a person's goals of care, their prognosis, their beliefs and values, et cetera. I'll just briefly mention that the real important part about deprescribing is that I do not look at deprescribing as a reduction of medications in regards to reducing the dose. I will only say I deprescribe something if I take it off completely and I don't replace it with another pharmacological med. And I also don't use deprescribing in the same way that some do with optimization, where optimization is looking at how to use what medications we have on board and how to tweak them to make everything work cohesively. Deprescribing for me is taking something off, pulling it off completely. But it's hard to implement in practice, right? And there's a couple of reasons why. The kind of biggest point that I hear in practice when I start talking about how important it is to deprescribe is I'll have providers say, like, Jen, nobody wants to deprescribe. Like, the patients like to stay on meds. And so I'm interested to see how you guys answer this first Zoom poll question. What percentage of patients do you think actually are willing to eliminate at least one medication if their doctor says it's possible? And I'm not making this up. This is actually from a study, as you can see. It was published in JAMA Internal Med, and I'll talk more about it once we have an idea of the answers. And then Bevan, you might have to tell me if I don't know if I'll see them.
Yeah, no, I can tell you. So it looks like it's kind of steadily shifting. So we're going to give it another moment. About 100 out of the 163 of us who are present have voted. So let's give it one more minute. But it looks like we've got about 15 people saying A. We've got about 26 people saying B. We've got 28 people saying C, and we've got 40 people saying D. We'll give it maybe 10 more seconds. Sure. But yeah, this is a great question. I don't know that I would know the answer. I'm trying to think of how I'm going to vote.
Sure.
All right. It looks like it's holding steady with the letter D being the case.
Right.
And so I'm going to move to the next slide.
Thanks, Evan.
All right.
So I'll just mention, for those of you who chose answer D, you are correct. That is actually the right answer. And so this percentage came from a 2018 study led by Emily Reeve, who Justin and I know very well, another researcher from Australia, who worked with Cynthia Boyd and Hopkins to utilize the US Medicare beneficiary data and the medication attitudes patient attitudes towards deprescribing survey to ask older adults, would you be willing to come off of at least one of your medications if your doctor said it was possible? And after doing some fancy schmancy statistics and accounting for certain cofactors, the answer was 92%. So why is that important? If you as the provider are coming to a patient and you say, I think this is possible, this aligns with your goals, X, Y, and Z, 92% of your patients will very well agree with you, and that roadblock no longer exists in deprescribing. Cool, go ahead, Bevan, you can move to the next slide. However, there are some other barriers to deprescribing implementation that I want you guys to be aware of. So just briefly, I didn't come up with this either. This is some work, one of the systematic reviews that is done by Kristen Anderson, again, out of Australia. I seem to love the Australians today, who've looked at what provider barriers exist in practice. And this is important because a lot of times I'm a pharmacist, I'm going to another provider to gain their acceptance of changing a medication plan. I also like to talk about the barriers to deprescribing, because if you're not able to think about how you're going to work through these situations before you get there, you potentially have a lot of landmines waiting to explode in your plan. So the largest, and what I think I see most often in practice is the barrier of awareness. A lot of times, providers are really good at saying like, yeah, of course we should deprescribe. That makes a ton of sense. But then when I start talking about really specific patients and how to do it, then they kind of are like, no, Jen, they're fine. Don't touch that. That also kind of plays into inertia as well. But so there's a little bit of a lack of awareness sometimes around what actually is the definition of a potentially inappropriate or unnecessary med. Does it really make sense for this particular person that I have in front of me? It can be challenging. The next, as I mentioned, is the barrier of clinical inertia. We in practice, and this is especially true in the nursing home, is if it is not broke, do not fix it, and kind of keep the course per se. This is especially important in the nursing home setting because for those of you who work in the nursing home, our goal is to keep these residents most of the time in-house. We don't want to send them out to a hospital where they are sicker. So making changes that we are unsure of can be challenging. We always want things to go well, but a lot of times we have to be mindful that things might also go badly when we change things. And then lastly, self-efficacy. We know that deprescribing knowledge and skills are not traditionally or consistently taught in today's health system learning. And so when you have independent practitioners that feel like deprescribing is really foreign to them, I can't blame them. They have been given years and years and years of training about how to start medications and how to do it in the right population, but they unfortunately weren't given the flip side of that, how to think about what population makes the most sense with these medications, et cetera. And so this is where I think academic detailing really helps, the self-efficacy portion. Okay, thanks, Evan. So our goal, like I said, was to develop, implement, and evaluate a deprescribing focused academic detailing program within a nursing home setting. And I often have to joke with myself here, what is the difference between calling this a deprescribing academic detailing program versus some of the other projects that I've seen some of the members on this call already perform? And I've thought about this long and hard, and the truth is I really don't know. I wonder if I call it deprescribing to give it a new name, a new sexy term, so that it kind of, maybe that alone changes someone's behavior. So you'll notice that I don't call it reducing, I don't call it optimization. I will call it deprescribing with the hope that it will perk up someone's ears and they'll pay a little bit more attention to kind of what's going on. So our aims for this project included essentially developing the program, looking at its feasibility and acceptability, and then talking about how it could support pharmacist-led deprescribing, because I agree with Justin and Mike Steinman that the literature, and I've seen this in practice as well, because that's what I do most of my days now, is when a program is structured around pharmacists, it tends to really help all of the other providers and prescribers involved. So Evan, we go to the next one.
Sorry, little glitch. There we go.
Cool. So we'll talk next about the methods. So listed on this slide are the proposed methods for this project. And this is when I really have to say thank you to the NaRCAD group, because you guys helped me develop these methods during the annual conference last year when we were in Boston all together. So I really have to say, this is when I was glad I was not a deprescribing expert and I could reach out to the true experts in the field, which was clearly not me. But our proposed methods were essentially, we would bring this interprofessional working group together. Our working group included physicians, pharmacists, and public health PhDs with expertise in geriatric medicine and palliative medicine. And our working group also included some important stakeholders within our clinical health system. So as you guys can imagine how kind of critical that can be. We then wanted to develop the academic detailing program. We went through and formalized this through the QAPI pathway within the nursing homes. For those of you who work in nursing homes, that essentially is the quality assurance performance improvement pathway. We decided to target 3 nursing homes in particular for this project. We decided to work with these particular 3 nursing homes for a couple of reasons. Number one, they had not been part of a academic detailing or a deprescribing initiative within the past 5 years. So we wanted to do that. So we kind of had a clean slate with each of these groups. We decided to choose these 3 nursing homes as well because 2 of them would fit the definition of academic. They had providers who held academic appointments, love to be part of projects, etc. But we also chose one nursing home in particular that would not, by definition, meet the criteria for an academic nursing home. It was in a more rural community outside of Western Pennsylvania and did not include any providers with academic titles. We decided to target proton pump inhibitors as the medication targeted within this initiative, and that was also chosen for several reasons as well. Number one, because academic detailing is the education of evidence-based medicine, there are few deprescribing clinical-based validated algorithms in the literature. Although, and Justin knows this too well, the Canadian group has published, validated a proton pump inhibitor algorithm. So we felt comfortable using that as our as the basis for our academic detailing materials. Number 2, we chose proton pump inhibitors because they are what you would probably consider a low-hanging fruit. Now, plenty of literature, including some of my own, has suggested that it is important to go after these high-risk medications, high risk being those medications that while they can cause adverse drug reactions, they can also cause adverse drug withdrawal events if deprescribed or discontinued. But we wanted to target proton pump inhibitors because the goal of this project was really to see how academic detailing would work in this setting. And we were worried that if we targeted high risk medications, we might, run into issues down the line. And lastly, we chose proton pump inhibitors because a lot of people are on them. So our hope was that we would be able to target most of the nursing home prescribers because they had at least one or more, in a lot of cases, of nursing home residents that are prescribed these drugs. And then lastly, I'll just mention again, when you think about working with the long-term care, nursing home setting, these are their homes, and our goal is to not disrupt their life and their process as much as possible. So we also wanted to choose a medication class that, again, would not change their scheduling a lot. Moving on, I'm sorry, Bevan, can you go back? I'm sorry.
Sure.
My bad. So with the academic detailing program, our goal was for the sessions to be driven by consultant pharmacists. And briefly, for those of you who don't work in a long-term care setting, consultant pharmacists are part of the interprofessional team you will work with in a nursing home. And per Medicare guidelines, consultant pharmacists need to review the medication list of patients at least once a month. So reviewing meds is part of their regulatory process every month. And we wanted to also make this really interprofessional. And so we wanted to have the changes of medications be made by the nurse practitioners, et cetera. The nurse practitioners will also play a crucial role in the monitoring of potential adverse drug withdrawal events. Our hope was that if something changed in the resident's symptom presentation, the nurse practitioners would be able to also step in and make changes. As a little bit of a bonus, and I'm sure all of you have seen, we also felt it was important to provide these nursing home prescribers with a little bit of feedback as well as an audit of their specific prescribing data. But we wanted to take that one step further. Within the private sector in Pennsylvania, pharmacists do not have a scope of practice without collaborative practice agreements. But thankfully, I was able to receive one prior to getting into this project. So we were able to review the charts of all of the nursing home residents receiving PPIs, and then whatever accepted recommendations, recommendations were accepted by the provider, then they were able to be changed by me, again, to reduce burden. And then we developed some measurement tools, which we'll go in a little bit. So Justin, again, I know knows this study very well, but one of the things that I think is really important is to think about how academic detailing really does work. The Empower study, which is the Eliminating Medications Through Patient Ownership of End Results, was essentially an academic detailing program around deprescribing focused on the patient as the recipient of the information. So we're talking about doing academic detailing for a provider. What do you guys think would happen if we did this with patients? So essentially, think about this. In order for one patient to discontinue benzodiazepam therapy within 6 months, how many patients do you think need to receive direct education about BZDs? So you guys can say, and again, I'm not making this up. This is actually the results of the trial. So just saying. I'm a huge fan of the Canadian work, Justin, you know that. So I know this answer, so I can put this in, but I'm really interested to see what you guys think.
That's cheating, Jen, come on.
I know, I'm cheating.
All right, Jen, let me tell you what you might not be seeing.
Please.
So it looks like we have a very small percentage who think the answer is A. Okay. We have about 34% who think that the answer is B for patients. The largest percent is at the moment about 40% of respondents think that it'll take 10 patients to everyone, and 20% think it'll be about 12 patients to everyone. So it's a not a super significant split between B and C at the moment. Okay. All right.
I feel like I really want Justin to say this answer, because this is just, this is Justin's creme de la creme. This
all right, I'm going to unmute him. I'm unmuting him. Here we go. What do you think, Justin?
I can talk now. Drum roll. The answer is B for patients.
It is. Thank you, Justin. Thank you.
So wow, I wouldn't have expected that. All right.
Yeah, I think this is really crucial to just, again, highlight to you guys. Again, I think one of the largest barriers to deprescribing is that people don't want to do this, and that, we need to keep the status quo. But the Empower study really shows us that for every 4 people we talk to about medication issues, one of them is willing to come off even a benzo, which a lot of patients I know feel really, really attached to. So thanks, Justin. I really appreciate that. Okay, so I just wanted to, again, show you guys our academic detailing material. You'll see it on this slide. I'm very sorry. I decided to make the cover and the back pretty small so you could actually see the meat of the material, which is on the slide here. So essentially—
But not to worry, Jen. We'll make sure that everyone gets to see the slides. So they'll get to blow them up and dive right in.
Yeah, and I'm more than happy to actually send this PDF to anyone. I'm more than happy to just let me know. So essentially the material, as you can see, started off with a little bit of feedback to the providers. I would actually write on the material where the providers' data really landed. We talked then about the concerns with prolonged PPI use and some of the particular risks that residents are at risk of with prolonged PPI therapy. And then the right side of the material, as you can see, is essentially the deprescribing.org deprescribing PPI algorithm, just in a different format. So it talks about how to identify opportunities for PPI deprescription, how to actually do it, and then how to think about monitoring. Our key messages, and I know these are very small, I'm very sorry, really focused on some of the risk of prolonged PPI use according to the literature. The next looked at how often to attempt a deprescribing PPI attempt, essentially because, as you guys can imagine, a functional status and goals of care of a nursing home resident can often change. So while we may not think it's appropriate at one instance, it may be important to consider not so far along down the line. And then the third message looked at how to really deprescribe, how to taper, and how to think about reducing that risk of adverse drug withdrawal events. Thanks, Bevan.
Yeah.
And then, like I said, we wanted to take this one step further. So as some of you have in your particular projects, each resident within the 3 targeted nursing home residents receiving a PPI were reviewed for deprescribing eligibility based off of the criteria within the deprescribing.org PPI algorithm. Say that 5 times fast. And the way we did this was through the SBAR format. Each of the residents had a similar situation. Essentially, we were reviewing all of these charts for PPI deprescribing eligibility. The background was customized to whichever resident we were reviewing. Go ahead, Bevan, to the next one. The assessment was based off of the criteria from the algorithm, and the recommendation, again, was customized to the nursing home resident, but in accordance with the deprescribing.org algorithm. Again, as you can see, if the provider, the prescriber, was willing to accept the recommendations, they could do it right then and there, and that's all I needed in order to go into a patient's chart and make those changes for them. Cool, thanks, Ben. But of course, this couldn't have gone completely smoothly. In fact, the Monday that I had scheduled my first academic detailing session was the Friday before the Sunday that Western Pennsylvania and all of PA went on lockdown in March of 2020. So that night I changed the entire methods of the project, which I know is not super great, but of course everybody has to live in our new world now. So essentially we changed everything to a virtual format. The academic detailing sessions, the chart reviews conducted by me, all of the accepted recommendations, our pre-post intervention surveys were all done online. But I have to admit, I think it actually went more smoothly with it being online. So I'll just mention that. Okay, thanks. So we'll talk next about results. And I'm gonna actually go through these pretty fast just because I know we have other things to talk about. So to start off, we ended up having 11 providers participate in the academic detailing sessions. Now, what was interesting is I actually got a response from all of them, either yes or no. Because of COVID, they all answered me, which I thought was very interesting. Their knowledge was statistically improved by the intervention, and they did say they were very satisfied with the overall kind of package for this project. There were 105 nursing home residents within the 3 targeted nursing homes that we reviewed. The mean age was 78 years old. This, of course, is Western Pennsylvania, so there were 70% Caucasian and 70% female. They were in the nursing home for a considerable period of time, just to give you an idea of these residents. The median number of scheduled medications was 13, and most were on omeprazole 20 milligrams or the equivalent. And again, I'll breeze through these. As you guys can see, the academic detailing session, which was about 10, maybe 12 minutes on average, statistically improved their ability, their knowledge of the 3 key messages, which essentially is reflected in those questions there. Got them. We'll go through this. I just don't want to. I want to be mindful.
You're good, but yeah,
cool.
We're almost at the end. No rush.
Yeah, perfect. So again, on this slide is just a little bit about the post-satisfaction survey. It's what you guys can imagine. The providers told me, although I'm sure it's a little bit of bias considering I was the one administering it, that they felt deprescribing PPIs was relevant, important. The key messages made sense to their practice, and that they were likely to deprescribe in the future as a result of this visit. And then I guess they thought that I wasn't hard to listen to for 20 minutes, and that the printed materials were helpful. Go ahead.
And again, folks, we'll make sure that all the slides are available so you can really dive into this content. So not to worry, we'll have it up.
you guys saw, with accepted recommendations, I was able to make those changes on site. And the largest, again, fear sometimes with deprescribing is this withdrawal of
Jen,
adverse drug. Yeah.
can we pause for 1 second? It sounds like you're going in and out. Do you mind if we take a second? You sound just like there's a little glitch where you sound underwater. So if you don't mind kind of hanging up and calling back, that would be awesome. And we have a lot of stall tactics up our sleeves. So we'll give you about 90 seconds to do that. And let's see. There we go. All right. So while we're doing that, I already see a couple of questions and comments. And Justin, I'd love to put you on the spot to reflect on those if you'll allow us. So I know you responded to Sadie Liller's question about the very first poll that Jen came up with. Did the 92% of folks who said, that they would be willing to come off of a medication, did that include opioids or benzos? And it was hypothetical. It wasn't, would you be willing to come off of a specific medication? It was to reduce any, correct? Was there any discussion about that at all? Because Sadie has also said, depending on which medication, it might alter how willing they are. So what are your thoughts about that?
I think it's a great question, Sadie. From my role as a pharmacist, I'd say, well, there's no way my patients would have ever come off the sleeping pill, and opioids is just a no-brainer. It's tough. A couple of comments, I guess, to reply to that is, one, it was fascinating in the Empower trial where patients were sent a brochure and said, hey, do you want to stop? That 27% did. In fact, out of those that didn't, the main barrier was actually us as healthcare providers, where their doctor or pharmacist said, no, look, you haven't had a full yet, so stay on the benzo until you have the full. So I thought that was fascinating that patients actually are willing. In the deprescribe trial, which was the follow-up, where actually pharmacists handed the patient education to patients, and pharmacists wrote a letter to the family doctor to say, hey, I spoke to Mrs. Jones about stopping a sleeping pill. We actually asked that question to all participants at baseline. And interestingly, there was no difference in those that said, no way would I ever stop a medication. Just the same percentage stopped as those in the intervention that had said, yeah, I'd be willing to. And in that case, we looked at non-steroidals and sedatives. So to me, what it shows is that while the majority of people say I'd be willing to stop a medication, it doesn't mean they actually will when it comes to their beloved benzo or opioid. However, conversely, the studies have shown when we actually educate patients, even if they would just out, no way would I stop my benzo or opioid, they're just as likely to. So I think it's great to overcome our fear that patients don't want to stop, knowing that they really do. But even those recalcitrant, reluctant patients will still change their mind if approached in the right way.
Awesome. Thanks, Justin. Looks like we have Jen back and in action. And Sadie says, thank you, Justin, for taking that question. I see a bunch of other questions and responses coming up. Yeah. Keep them coming. We'll turn back into Jen. Jen, take it away. I'm going to go back to the Zoom poll. Are you with us?
Yes, please. Thanks, Bevan.
Okay, great.
So hopefully I don't sound underwater now.
No, you sound great.
Perfect. So essentially, as we've been talking about, one of the other barriers to deprescribing is this fear of adverse drug withdrawal events. So I'm going to ask you guys, what do you think the literature actually says about the risk of rebound hypersecretion in a patient who was previously on a PPI? What do you guys think it is? 16%, 32%, 44%, or 58%? Again, I'm not making this up. This is actually the literature. And then I'll tell you.
All right, Jen, I'm going to tell you what I'm seeing.
Yes, please. I know the
answer.
All right.
Oh, I know you do. I would hope you did. Okay, so it looks like it's an pretty even Steven between A and B. A is kind of climbing, so we think it's 16%. About 30 people think it's about 16%. We've got about half the people responding, so folks, go right ahead and just take a stab, take a shot in the dark. What do you think the risk of rebound hypersecretion is within 4 weeks? So almost a whole month of discontinuing a proton pump inhibitor. All right, we've got about half the people voting, and it looks like if you go from A to D, we've got 46% of respondents saying A, 37% saying B, only 10% saying C, and 7% saying 58. Jen, what's the magic answer?
So the answer to the literature is actually C, 44%. But let me be clear about where this number comes from. So this was a systematic review and meta-analysis that, as you can see, was published in 2013. It included only 5 studies. And in all of the studies, all of the studies actually cold turkey stopped the PPI. There was no tapering. There was no reduction of dose. So I think it's important to look at this number with a grain of salt because that is not what I've seen in practice, but that is what the literature says. Thanks, Bevan. You can keep going.
All right.
All right, so in regards to the chart review and recommendations, the challenge and the real surprise for us during this study was that only 20% of our nursing home residents were determined or deemed to have a deprescribing eligible PPI. That was much lower than we thought we were going to see. The reason that most of our nursing home residents were not receiving a deprescribing eligible PPI was because they were receiving some other medication that independently increased their risk for GI bleed, anticoagulants, aspirin, NSAIDs, etc. And so because we wanted to be mindful of GI prophylaxis, and we decided as part of the study that we would only focus on PPIs, we did not touch those. What was nice though is that of the 20% that were deprescribing eligible, 6 of those orders were able to be placed, essentially because those orders were of nursing home residents, of providers / prescribers that we met with during the academic detailing session. The other 15 orders you guys see there were with nursing home residents of prescribers that were not able to meet with us due to COVID. So we did not feel comfortable changing orders without meeting with those prescribers as well. But at 2 months, all 6 of those had no issues with any rebound hypersecretion, and they were all successfully deprescribed.
Amazing.
Yeah. So I'll skip through these just for the sake of time, but feel free to take a look at these if you guys want to learn more about the population that we took a look at and see if that makes sense for what you guys are doing moving forward too. Cool, thanks, Bevan. Go ahead to the next one. So essentially with the discussion points, again, the surprise for us was that only 20% of our orders were considered deprescribing eligible. It really emphasizes the need for these multi-morbidity guidelines around deprescribing. In regards to limitations of this project, it was QI based, so we did not perform a sample size or a power calculation, and our post-survey was susceptible to response and social desirability bias, as we kind of talked about. I was the one giving them out, so go figure, they liked everything. And there really wasn't a size for meaningful improvement determined before that. But here are the lessons learned and the steps moving forward for us. So number 1, determining deprescribing eligibility opportunities is challenging. As we talked about earlier, we decided to target PPIs for numerous reasons. I think we would probably make that decision again, but of course, when you target different medication classes, there are different pros and cons to those approaches. And while I love deprescribing.org and all the work everyone does in this field, what became a challenge for us was that the deprescribing.org algorithm maybe wasn't as malleable as we hoped we would see in the nursing home population. I'll admit that when you look at the prevalence of potentially inappropriate PPI use in nursing homes compared to our population clearly had a much lower prevalence of these deprescribing eligible opportunities. The literature suggests it's much higher than that. So our group internally wondered if that's because Pittsburgh is a referral site for a lot of cardiovascular interventions, and therefore a lot of our nursing home residents have considerable cardiovascular diagnoses, thus the higher prevalence of anticoagulants, aspirin, etc. Maybe that was what it is. And again, regarding generalizability, of course, our methods had to change pretty fast due to COVID. And of course, we need to be mindful of the fact that not all consultant pharmacists are able to change orders in the nursing home setting without a collaborative practice agreement. I joked with Justin before we gave this presentation that my life now actually mainly involves working with the consulting pharmacy groups in Western PVA so that all of the consulting pharmacists have collaborative practice agreements so they can make these changes on site. So yeah, so academic detailing is a useful technique, and I would suggest using it for any of you who are looking to deprescribe in any setting. So yeah.
Awesome. Thank you so much, Jen.
Yeah.
We really appreciate it.
Yeah.
And we do have only about 10 or 15 minutes for Q&A, but it's still quite enough. So Justin, I think what we'll do is just have both you and Jen answer these questions rather than have any more didactic, and we'll open it up to our pals from the chat box. All right. So just as a quick hurrah, we do have Jana McNulty from Ontario saying that she really found the Empower trial brochure so helpful that clinicians always wanted copies of it. So that's always nice to hear. Sometimes we do this work and we feel like we're doing it sort of in a void. And so whenever there's a chance to hear back about tools that are working well, it's really terrific. So thanks so much about that. Narissa has a great question from Chicago here. How did you get your foot in the door with the nursing home in order to provide these services? You know, thinking it would be a great target for education and deprescribing, also probably considering there may be folks who are so stressed based on the responses to the poll we asked at the beginning with so many different things going on that bringing in one more thing would be stressful. So talk to us about gaining access and some of the things you did there.
Yeah, sure. So as I mentioned at the top of the presentation, some of the key stakeholders within our health system were part of our working group. So I'll mention that, and I'll disclose that a lot of our access came from the fact that we had the director of our nursing homes here within the UPMC setting as part of our working group. And so we really leaned on him to direct us on how to best engage those prescribers. Number two, I know you talked about workload. Our goal with this project was to make it as prescriber friendly as possible. So as you can imagine, the way we designed the intervention was really most of the work could be done by me or the consultant pharmacist. So not only were we the ones doing the academic detailing, but we were the ones that had already reviewed the chart prior to meeting with the prescribers, and then we were able to make those changes on site. As with many pharmacists in many different settings, we were also able to do the monitoring because we were already on site as part of our scope of practice as well. So I think the success with our project really came from our ability to leverage a current scope of practice for a pharmacist and to make it as user-friendly as possible. I like to think we wrapped it up in a bow and I handed it to them within 20 minutes in and out, and they could have everything they needed from us. So.
Awesome, thanks, Jen, great answer. I have a bunch of other questions here and I'm gonna pick them in the order of sort of flow. So don't worry, I'm going to try to get to all of you. From Lauren Regier in Canada, did you have any family feedback of interest? Great question. We often forget not only that patients are the endpoint, but that they have the support system who wants to know about their care, especially the elderly. So great question. Thanks, Lauren.
It's a great question, Lauren. So for this particular project, we did not engage family members. However, the reason we decided to do that was because in previous deprescribing initiatives within these nursing homes, we did and found it was considerably helpful. Again, the goal of this project was to focus on how we could use academic detailing as a disseminating and implementation tool. But I'll admit I do this in practice all the time. We did not for this project though.
Thanks, Jen. And thanks to Elizabeth Fowley-Moss from Maine for suggesting we pull out of the slide deck so we can see everybody's faces. We will go back in a moment, but yes, it's really important for us to feel like we're in some sort of room together. All right, I'm going to share a quick question from Mike that he's dying to ask, and then we'll go back to all of you. Mike, go ahead.
Oh, great. Thanks. This is actually something as we've talked more about deprescribing. Jerry and I have talked about it a lot, and so to give fair attribution, we've talked about the term deprescribing, and I thought, Jen, you made a very sort of candid statement that maybe it's just a way to sort of have a buzzworthy term of something we've all thought about for a while, of avoiding medication overuse and rationalizing and so on. And there is that concern. Does deprescribing, I can see where it appeals to some and might feel to others like you are taking something away. And in one of our discussions, Jerry had mentioned to me that Lown report, Justin, that you cited, talked about it as medication overload as opposed to polypharmacy and deprescribing. So I'm curious, maybe I'll kick it to Justin first to let Jen catch her breath, but both of you can comment on it.
Justin's the expert on this one. Go ahead, Justin.
Yeah, or maybe just kick this one, Justin. How do you think about that, the pros and cons of deprescribing and where we might get some pushback on it as a term that could create a risk of feelings of abandonment or other unintended adverse consequences?
That's a great question. I guess deprescribing resonates well with healthcare providers. It's been around for 10 years now as a phrase, and we're using it a lot. Probably not a word I use with patients much. We've just done a survey a couple of years ago across Canada, and only 6.9% of older adults had ever heard of the word. So I guess if I'm going out to talk to a patient, it's not really something they're going to go, huh? I don't know what that means. So there I would probably, sorry, Jen, use appropriate medication use. But I guess some of the work Barb did in Ottawa was with a marketing company saying, how do we market this? And it really went back to some of the phrases that came out was, what was good for you then might not be good for you now. Your life has changed or things have changed. Maybe it's time your medicines change too. And that approach at the patient level, I think, works really well rather than the buzzword of, hey, deprescribing. But I find in my clinical role, saying deprescribing, oh, well, that's great. Yeah, of course, I want to know about that. So it depends who I'm marketing to. If it's academic detailing to a patient or to a doctor, I'm going to use different words.
That's actually a very useful framing to think about it in, Justin. I appreciate that. And similarly for going back to our theme of sustainability, for people who are thinking about these as programs and maybe engaging with stakeholders who are sort of have health system responsibility, but then thinking about what's the messaging for the patients as well. Thank you. That's really helpful.
Yeah,
Jerry,
so I'll just mention, sorry, Bevan.
Oh, no, you go right ahead, Jen.
I knew Mike was going to ask this question, so I specifically did not go through this on my slides. But you guys will see, if you guys are interested in looking more at our academic detailing materials, we actually do not use the word deprescribing across the board. We actually call it defarming. And that's actually an acronym. It stands for the discussion to ensure the patient-centered, health-focused, prognosis-appropriate, and rational medication regimen. I don't know if I copyrighted that. Maybe I should. I don't know. But essentially, we felt when we did internal kind of informal surveys of our groups, I agree with Justin, deprescribing did not connect. So we ended up using defarming, and that somehow connected with our group, and that's what we use. So you'll see that this project was called the Defarming PPIs project.
Awesome. More acronyms all the time. And I was just going to make a quick reflection over to Jerry's original studies. And what this made me think of, Jerry, was the unad about, sometimes the female patient just needs like a tuck-in instead of a medication. So I think it's really interesting in terms of marketing, especially for those of you who are thinking about your own branding. How do you look at conveying key messages and related materials to clinicians in a way that's very unique to the vulnerable population you're working with? So, but I want to make sure you guys have some room. We're going to go to 3:50 with these questions, and then we'll wrap up a few minutes early so you can fill out your evaluations. All right. So we have a great question from our pal Jackie Travers, who also ran the storytelling workshop today with her colleague Reagan Smith. Hi, Jackie. She says, I'm wondering if staff turnover, which we all know is just such a huge problem, and long-term care, and was one of the things that folks identified in our original poll before this session kicked off. Does staff turnover, did it have any impact on your efforts for this project? And Jackie's also worked in long-term care, and she says, for one of our projects, it felt like we were constantly having to go back to the beginning and re-educate new staff. What are your thoughts, Jen?
Yeah, so I will admit, full disclosure, that Western PA, I don't know why, does have a lower turnover in the long-term care and post-acute setting. So full disclosure there. However, again, I think it just goes back to for this project, we targeted the prescribers, and it was all wrapped up in a bow. So I only needed 20 minutes of someone's time in order to make these changes. And then we took responsibility for the monitoring. So whenever we did have any type of staff turnover with the residents we touched, all I did was, take that 5 minutes to introduce myself to them and talk about how really I could take on the burdens of changing this medication regimen, and then I would update them accordingly. And then we just use secure emails and texting, et cetera, to just keep everyone in the loop. So I agree. It's a challenge.
Cool. Yeah. Yep. Quick comment from our friend Brenda, who's also one of our facilitators to train folks on academic detailing from Canada. She says terminology is so important for both the patient and in the literature, and thinking about, switch hitting when something is being directed to a patient, saying, deprescribing or defarming is different than saying dose reduction, right? So just using the terms that are easily accessible. Great point, Brenda. All right, we have a question from Teresa Grund. As you increase the consultant pharmacist CPA and the scope of practice, do you plan on using AD as an avenue to educate those pharmacists on their prescribing practices? So what's the future looking like, Jen?
Yeah, absolutely. In fact, my hope was that it was planned for them to be a crucial part of of this particular project. The original methods were that I would educate the consulting pharmacist, and then they were responsible for doing each of the academic detailing sessions. Unfortunately, because of COVID, that had to change, which is what it is. But yeah, our hope is that once we have all consultant pharmacists in working at the full scope of their practice, then we'll also work to ensure they feel as comfortable with the literature as well.
Awesome. Thanks, Jen. We have time for one more question. So if someone wants to either raise their hand or pop it into the chat box. Mike, I know you're on deck with things. Jerry, I'd also love, if you don't mind, to put you on the spot for your reflections, just going back to those original studies, looking at where we are in 2020 and what your sort of response to this presentation has been, and where you think long-term care might be going in the future with AD. So thoughts from Jerry.
Sure. I will be brief. It is both good and strange to see that 30 years after that first study, people are doing innovative things, bringing academic detailing to nursing homes, because I guess I thought back in the early 90s that as soon as this paper comes out in the New England Journal, within 6 months, everyone's going to be doing this. And it just is a testimony to how much you need to keep kind of pushing to get this to happen. But I applaud this new generation of work. I think it is going to be real important. It would be wonderful if we had a healthcare system that kind of automatically did this, so that there was an ongoing look at patients' regimens with an eye toward making them better. And every 10 years, somebody tries that, and then it kind of recedes into the background. But this is a very important new iteration of that work. And I guess the last point I would throw out is that we were also able, when we did this for benzos and antipsychotics, we were also able to show that patients' cognitive function improved, not because we had figured out how to cure Alzheimer's, but because if you take away unnecessary sedating meds, people wake up and sort of remember who they are. So it's real important, both from the prescribing side, but also from the outcome side. And so keep doing it. Thank you.
Thanks, Jerry. That's lovely. All right, so we're wrapping up. Want to say a huge thanks to Justin and to Jen. Any final thoughts, Jen and Justin, just about, sort of where the future of long-term care might be going, and some goals, some hopes, some what you would like to see in the coming year? Justin, I'll start with you. What thoughts do you have? Yeah, I'm unmuting you. There we go.
Thank you. I'm pushing the mute button. Look, I'm really excited by this project. I've been running some focus groups in Newfoundland the last couple of weeks, and it really came up I was thinking of you, Jen, where pharmacists there said, look, if I can identify the patients and write down the deprescribing plan and give it to the physician, and the physicians on the group said, that's great. It'd be good if I could just tick the box and send them back for you to manage it. Sadly, that doesn't happen up this side, at least not in Newfoundland. But I think I was thinking of you and this talk in particular, and going, how much is the education of the doctors that I'm teaching you to be able to take ownership yourself? And a lot of the physicians on the focus group said, yeah, we just don't have time. We want you to highlight this as a problem, and we want you to have taught us that you are capable of doing it as a pharmacist. And I thought that was an interesting reflection from them about really what I saw in your project, that your role and the other consultant pharmacists could take over. So I'd love to see the growth of that area and see where you come up to in the next 12 months once you've got that group trained. But yeah, fantastic project.
Awesome. Jen, any final thoughts? Oh, gotta unmute you. There we go.
Thanks, Evan.
Sure.
Thanks, Justin. Honestly, I think all of us on this call do this work in some shape, way, or form. I just think I call it deprescribing to make it look cool. What I'll just say is that if anyone on the call needs anything, wants to take a look at the data from me, from our group, I'm more than happy to do that. Again, I'm not an academic detailing expert. My life has really been in this world. So anything I can do to kind of help, and I'm sure Justin would say the same thing. I don't want to speak for him, but we drank the Kool-Aid. We want people off these meds. Anything we can do to help you, empower you. See that, Justin, the empower part?
I'm impressed.
Empower you to deprescribe, we will do that. So.
Awesome. Thanks, Jen. We're so grateful to have had this as our last session, just to really close strong. And with that in mind, we're going to ask you all one more set of poll questions and then throw you our eval. Don't forget that if you fill out the evaluation, you can be entered into a raffle. Every day, NaRCAD will pick one person and donate $50 on their behalf, send it on over to you, just so you can feel some goodness, and we'll have a list of public health organizations and charities that you can pick from. All right, so get on back to your poll everywhere for just 2 more quick questions. What is the most valuable thing you learned today? You can pick a topic, you can pick a word, you can pick a phrase, type whatever feels good to you. And if you're not sure, think about what's one thing you'd steal from today and try to take back and implement. Storytelling, AD 101, AD and undocumented populations. Amen. That's the first time we've seen that. Thank you, Nate Rickles from Connecticut. Empathy, lovely. Sustainability, essential for provider impact, potential of pharmacies to help with disparities. Yes, yes. Oh my God, they're coming so fast that I actually can't read them all, which is sort of lovely. And we will share all of these responses with you. We'll take screenshots, we'll do what we can, but really seeing just so much positivity here, learning how to tailor your message, all of these other great things that I'm trying to scroll down on. But wow, okay. Well, thank you, everybody. And one more future-based thing. What is something you didn't learn today, but you're hoping to learn tomorrow? And it looks like marketing was from the last one. Really glad to hear that the brand building, Build a Brand workshop was so helpful. All right, what do we want to learn tomorrow? More about health disparities, evaluation, learning from our colleagues based on their experiences, getting buy-in, how to create materials with limited staff. That's something I may need to help you out with one-to-one after the conference. So whoever did that, go ahead and pop me an email. Wonderful. How to explain academic detailing to get signups. Again, something we here at NaRCAD have been working on for the past decade, and I think we've got it down by now. So we'll share that. COVID-specific program building help. Wonderful stuff. AD for clinical staff. So if you don't get any of these goals met the way you need to over the next 2 days, we are here for you. This is not the only time we will convene with you. So with that in mind, what we want to do next is, along with taking a quick look at tomorrow, we have one of my favorite things, which is our annual address from Jerry Aborn, always insightful and entertaining. We have a plenary session on e-detailing. Yes, who are the people who are a few steps ahead that can share all of the things they've learned to do well? And please don't do it this way. We've done it, it doesn't work. All the folks who are going to share that great stuff, we're really excited. We have an expert panel on the ways that pharmacy, who often don't get, community pharmacy don't often get as much of a spotlight on them for working on the opioid crisis as, clinicians and emergency departments, and they're equally important. So we're going to talk about that critical link between pharmacy and opioid safety. And then in the afternoon, we're going to have a lovely special presentation from our pals over at Alosa Health on AD for type 2 diabetes. All right. It's been a mouthful today. It's been an earful, but you guys have been amazing. We appreciate your incredible questions. If there's any that pop into your mind tonight, in the middle of the night, tomorrow, don't hesitate to let us know how we can help. We will have contact information for the presenters up on our archive at the end of the week. And going to ask you now to stick around and use these last 6 minutes not all of them will be necessary. To fill out our eval, if you want to be entered into the raffle, you do have to use your name. So if you're not happy about something and wish to remain anonymous, no raffle for you today, but you can try again tomorrow. Anna just went ahead and popped the evaluation link in the chat box. It's narcad.org/eval, and you'll see a link to click. We appreciate your feedback. Not just appreciate it, but we need it. We need to know what we're doing right. We need to know what we need to do better. And especially since this is day one of our very first, convening virtually, we definitely are going to lean on you to tell us what direction we need to go in and if we're in the right ballpark. So I want to say thank you and turn it over to Mike Fisher to also add any closing remarks. Mike, how are you feeling about today?
Really grateful to everybody for sticking with it. We've at various times over the day, I don't think we've ever dipped below 140 or 150, and we've been up over 200 some of the time. And I know, given all the time people have spent on Zoom calls, your connection and your dedication to stay with us is inspiring. That's why we do what we do. So I really am grateful. I do want to call out some of our international colleagues. I saw it on top of all the people saying they really enjoyed today, Deborah from Australia saying she really enjoyed the night. And if you think about the time difference, the fact that I saw Deborah logged on for the entire set of the conference today was pretty impressive. So, and I know some of our colleagues from Europe and others have really been coping with some impressive time differences. So thank you for your dedication, for your willingness to connect, and to our team for making the first day possible. We'll do all of those big thanks at the end of the whole conference. But it's exciting for us. This is more people than we've had together at once in our in-person conferences, and it really epitomizes making an opportunity out of a year that's a challenge. We unquestionably were sad when we realized that we would not have an in-person conference the way we usually do. And there's a lot that we miss about it. And we certainly will be excited when we can go back to them. But the fact that we've been able to reach more people, to have more people listening and engaged at once for some of this education and community building than we've had in prior years is a good thing. And this is a year, if ever there was one, when looking for good things is important. So thank you for all of that. And please continue filling out your evaluations. I absolutely second what Bevan said, that we want your feedback. We're learning how to do this do this as we go. We have a great team, but we always are looking for suggestions on what we can do better.
Awesome. Thanks, Mike. And I just want to again say, as Mike did, thank you to all of our presenters today. We really just had such a wonderful time learning from the clinical diversity panel in the morning with those field presentations. Hopefully you all had some nice hands-on, well, virtual hands-on learning in your breakouts. We're excited to hear about those, always trying to curate new content for these workshops that we have. And then, of course, wrapping up with AD and long-term care settings, just a really wonderful kickoff. Other thing I will say is thanks to all of you, not just for, as Mike said, sitting through what is inevitable in terms of Zoom fatigue, but also knowing it's hard to stay focused. It's really hard to just even kind of show up on days when there has been so much stress. And so please, for those of you who've gotten a taste of how we're going to, roll these sessions out over the next 2 days, please come with questions. Don't be afraid to pop them in the chat box. Don't be afraid to throw your hand up and say that you want to talk, or when you pop a chat box question in saying, I'd like to elaborate. We do want to hear from you. And for all of you who are thinking, hey, I want to present next year, start thinking about it. Start thinking about the stuff you're doing, the stuff where you'll have data, even if you're halfway through a project and you're not sure where it's going. We really want this to be as much of a learning collaborative as possible. And you don't have to be an expert of 10, 20 years to be able to share something really meaningful. All right, we've got 60 seconds left. Wishing you all a wonderful rest of your day. For those of you who are in other time zones where it's already the middle of the night, get some sleep, and we'll see you all tomorrow. Thanks so much. Take care, everyone. Bye-bye. Thanks for being here.